Thank you very much, Professor Floridi. Dear colleagues, it's a really great honor for me to introduce this symposium on behalf of the Fondazione Cini and on behalf of President Rocca. President Rocca will actually address us tomorrow. This symposium is about global health in the age of artificial intelligence. And as we all know, medical care and the organization of health systems are changing rapidly as a result of scientific and technological innovation in diagnostic, in therapies, and in the use of data. Artificial intelligence is part of this process of change, and so this symposium focuses on the multiple effects of artificial intelligence on medicine and their ethical and social implications. Professor Luciano Floridi is the scientific director of the symposium. He is the director of the Digital Ethics Center at Yale University. He's also professor at the Department of Legal Studies of the University of Bologna. I would like to thank him for his great work. The symposium is promoted and hosted by Fondazione Giorgio Cini. Fondazione Cini is a cultural institution established about 70 years ago in 1951. It includes several institutes devoted to the history of art, of contemporary art, ancient and contemporary music, theater and opera, the history of Venice, and cultural dialogue among different religions and civilizations. Fondazione Cini organizes expositions and concerts. It manages important libraries and archives. Over past decades, Fondazione Cini has organized and hosted lectures, seminars, and conferences on a wide range of topics, mainly on humanities and cultural heritage, but very many meetings focus on scientific issues, and several of them focus on the medical field. The world's leading intellectuals, scientists, and academics contributed to the discussions. Fondazione Cini has also been a meeting place for discussing major international policy issues. For instance, 2 head of government G7 meetings were hosted on this island. Therefore, this symposium is part of a long-standing tradition of interdisciplinary research. Over the years, we have seen how the interaction of different disciplines, humanities, philosophy, social sciences, law, physics, engineering, biology, can improve the understanding of complex issues and lead to important innovations. This is the spirit of this symposium, a space where different perspectives meet, merge, and inspire new way of thinking. This symposium brings together an exceptional group of individuals, thanks to Professor Floridi, leading researchers, passionate scholars, and bright young minds. We are here to share our knowledge, challenge our ideas, and push the boundaries of our respective fields on the topic of global health and artificial intelligence. It is your active engagement that will make this event a success, and I encourage you to participate in the discussions. This symposium is the first of a series of initiatives that will address some of the most pressing challenges of our time, from pandemics to migration, from climate change to demographic change. We hope that the ideas we generate here will resonate far beyond these walls and far beyond the lagoon, helping to shape future research and international collaboration. As you all know, we are living in a world marked by rapid and sometimes unsettling changes. Geopolitical tensions are rising. The global economy is increasingly uncertain. The global dialogue is frequently under pressure. As the international landscape continues to evolve, we must be prepared to rethink our approaches and to respond to these challenges with innovation and resilience. It is precisely in times like these that the role of scientific research becomes even more critical. Our ability to address complex global issues depends on the strength of our collective knowledge and the creativity of our solutions. The global cultural dialogue is crucial. We should keep this in mind. Fondazione Cini will try to contribute to this dialogue from the San Giorgio Island. In closing, I want to express my gratitude to all of you for your presence here and your commitment to advancing knowledge. There are several young scholars and researchers here today, and I believe your ideas, your energy, your curiosity will certainly shape the direction of research in the years to come. I'm confident that this symposium will provide you with valuable opportunities to learn and to contribute to the global scientific community. So, thank you very much. I wish you all the best for the coming days, and now I pass the floor to Professor Floridi.
Thank you so much. Lovely words. I'll get it. Thank you. Well, we could not have started with better words to explain why we're here. My task now is to live up to the challenge that our director has shaped. I told you that before sharing with you some remarks, there are bits of information that I like to share. The first one is a change in program. You will have on the table the updated program for this afternoon. Unfortunately, as it happens, speaking of health, Effie Vallena was unwell, so she will not be able to join us. Reshaping the program means that I will still be with you for some opening remarks on the symposium. We will then have Jessica Morley with a 45 minutes presentation framing the debate that will follow for the rest of the symposium. A bit of Q&A, and I'd like to spend a word on this in a moment. Then Ravi Parekh talking about the ethics of AI in healthcare and principles of ethics. Some more time for Q&A, and then a break. So roughly not so much different from what we were planning, but we will miss Effie, to whom we send our best wishes. I said a few words on the Q&A. That is the second point I want to share with you in this quick list. This is not your ordinary conference. We're not supposed to have long speeches, short time for interaction, another long speech, short time, goodbye. Even the way in which we shaped the room, and trust me, it took quite a while to understand what the best shape was, is meant to facilitate conversation, interactions. So please, during the Q&A, share your comments, your questions, your uncertainties, your objections, your requests for further clarification. As we all know, because we all belong to academia one way or another, the only question that is a bad question is the question that is never asked. So by all means, please, let's take advantage of that time, and it's a long time to make sure that more comes out of this meeting. There is a reason for that. It's not just to be nice, but at the end of the meeting, we have two rapporteurs. I would like to ask them to raise their hands so you can recognize them over there, table 4. And our rapporteurs will synthesize the 3 days in a document that will seek to achieve 2 goals: a shape of the current state of the art, where we are when discussing the topic of AI and global health, and, more importantly, a second part with recommendations to the policymakers, the lawmakers, the decision makers, the makers out there in the world who can make a difference. We do the thinking, we can do the planning, but unfortunately, the days when philosophers can finally get to the White House don't seem to be around the corner, and therefore we still have to delegate to someone else in Brussels or in the White House or elsewhere the final decisions, but at least we can give them the right input. So please remember the presentations, the discussion during the coffee break, anything that we will be elaborating among us in this exceptionally qualified group of people can be transformed into a set of remarks and recommendations. Remarks about where we are, recommendations of where we want to go. With that in mind, the responsibility is high, but also the excitement. We can actually make a difference here. So that leads me to the next topic, which is why me? Well, each of you has been carefully selected. As you probably remember, we met for the first time online. You got an email out of the blue, thinking, is this something like a joke, or should I take it seriously? I'm glad that you didn't think it was a joke. The reason for that email was that we at Yale, with the whole group, Jessica Morley, and all of us decided that those were the people we wanted to talk to, listen to. So if that sounds like a flattering, well, it is. You are the best. We had, thanks to the foundation, the opportunity, the means, and the vision to ask the best to come today in Venice. What else could go wrong? The trouble is that when you ask the best and you have a high goal and a lot of ambition, there are no excuses for the failure. It will be ours. We will not be able to blame the lack of funding, the lack of time, the lack of expertise, the lack of knowledge, the lack of goodwill. It's all here. So please, 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 let's do a good job, because I can't go home saying, oh man, I really failed badly here. There are another couple of little points, and then we start working. Question time. The people in the back have done an amazing job. You will see lights, etc. But there's one tiny little technical thing that I need to remind you. When, as soon as, not if, but when you want to ask a question, please raise your hand. They will activate that mic that you have on the table. So raise your hand, pick up the mic, and we go. It's quite simple. Please do not start talking, because we will not be able to hear you. But raise your hand, phone, and we go. So that was the last bit. And I need to remind you that we are streaming some of the presentations, the keynotes, and some of the remarks. We will be recording the whole thing. Welcome to the digital age. If you sneeze, it will be there. The recording will be used for that white paper that I told you about, and will not be circulated for any other reasons. But if you have anything to object to that, well, let's meet later, because, of course, it has something to do with your privacy. Finally, real last point, an invitation to all the speakers, myself included. We have, as you can tell, a really tight schedule. It's done on purpose. We want to keep busy. This is not a holiday. That's for Saturday afternoon and maybe Sunday. So 2 things, please. Whatever you see on the program, that's the real time. 2 o'clock means 1400, Marine style. We start at that time. Second, if you have a 30 minutes talk or if you have a 15 minutes remark, etc., please look at that clock. It will tell you when to stop. And when that goes off, that's the end of your time. So please respect the timeline. It's quite tight, and we need to go through it carefully enough. Now, with this out of the way, some remarks. So we can actually show the slides. Oh, sorry, I forgot something. I have a terrible cough and cold, so I'll be sneezing and coughing. Luckily, not far enough from you, enough not to convey anything. This introductory remarks are meant more as a pre-reflection on what might be happening during the next 3 days. The real framework will happen when Jess, also known as Dr. Morley, will join us in about 39 minutes. And so I would start waking up when she joins us here. This is more a warming up, if you like. So I like to concentrate on 4 big areas. The digital revolution, we all know about it. I just want to make sure that we are on the same page. Something that I like to call, in a sort of romantic way, philosophically speaking, the eclipse of the analog. More on this, and you will hear, I'm sure, more about this topic as we go through the next days. Then a few words on regulations and a few words on governance. The digital revolution, we know that this thing is complex, not just complicated. The distinction is quite obvious. Complicated, it means I don't get it. No, it's complicated, sorry. But complex is something that belongs to the system, not to my understanding. When I say that that particular equation is complicated, it's because I don't get it. For a mathematician, it's perfectly fine. If I say that an equation is particularly complex, I mean complex for a mathematician. So in this case, the digital revolution is complex for the people who know about it, not just in terms of, oh my goodness, can't make head and tail. It is complex in the following sense. I put there a little bit of a network to remind you about the point. There are so many different variables that change very quickly, profoundly, interacting with each other. So the arrival of artificial intelligence is not a new revolution. I hear people saying that. The truth is that it's a much bigger book. That is a chapter. It's a chapter that has left and right the internet and the web and social media. Data, big data. Now, remember the new oil, bad metaphor until yesterday? Metaverse, extended reality of all kinds, but also all possible robots around us. And all that mix and match, constantly evolving. So it is really a digital revolution where at the moment, today, we decided to concentrate on AI because that is, if you like, the chapter that is being written that is modifying all the other chapters. But I know that, and you know, and I know that you know, that if we had met a couple of years ago, could have been maybe blockchain, or maybe the metaverse, or maybe big data, or maybe social media, mobile phones. Every year you pick up, there is a new flavor or a new chapter of that digital revolution. So let's keep the view open and not forget, as we will not during the next 3 days, that, for example, AI without high-quality data is a piece of junk. The AI without a network within which, for example, that particular agent has to interact is also a piece of junk, and so on. So everything is connected. Well, thank you so much. And that's why it is complex or complicated. In terms of time, we live in a very hyper-historical society, a society that depends increasingly more on its ICTs. Prehistory, no ICT. History, when ICT appear, basically writing, we start linking our well-being with the development of anything that has the ability to have records of the past for future consumption. That recording has another massive transformation when the recording became also a huge ability to disseminate whatever was recorded, alphabet, the book. After that, we have increased the pressure of the well-being individual and as a society on the presence of the current ICTs by developing digital technology. Recording, dissemination, manipulation. Alphabet, book, computer. Oversimplified because I know that you know. But that's why we have more history, no less. We live in a hyperhistorical society. The space we have is also a space that is increasingly an environment. In the 90s, the American legislation, the American government made the mistake. It was understandable at the time. They were not, as usual, listening to philosophers, and they thought that the internet was a communication revolution. It wasn't. It was an ecological revolution. We just started building the space within which we spend our life. An ecosphere, infosphere, cyberspace, whatever you want to call, where we are operating. So that too is part of this revolution. So time is hyperhistorical. The space is actually an infosphere. And within that infosphere, there are new agents. Not intelligent, not smart in any possible way, not conscious, not aware. They have no intentions to run away with my credit card, but they do things instead of us, for us, better than us. Agents have been around for a long, long time. I know you don't, but people outside should not believe the new agents sort of rhetoric today. For people with white hair in the room, we've been discussing agents for decades. Okay? But now they become something that you have on your mobile. So it's not just research. And as they interact with you and you interact with them, you have a space made of digital, not only analog world, an infosphere in a time that is dependent on technology more and more in terms of hyperhistory, with a board, if you like, a chessboard with new pieces on it. The interaction with those pieces is part of the complexity of all this. So what we need is actually more, not less intelligent. Next slide. And a new battery, if you can. We need more cooperation in all this so that the work that we're doing together is not just competitive, but also collaborative. Not for today, for another time, for another conference. But having seen where democracy is going, I think that the old style, competitive-only, consumeristic approach has seen its final days, I hope. Now, this is in terms of background. Next slide. The eclipse of the analog. What happens to all this when we look at the digital profile of each of us? Next slide. We know that everything we do, especially in health, but not only, I'll show you in a moment, everywhere, is data-driven. The identity of your patient, but not only, more on this in a moment, is digital. And therefore, we treat the person as personal data. In fact, actually, even the European legislation describes us as data subjects. Once you deal with data subjects as opposed to citizens, with data patients or digital patients as opposed to Peter, Mary, Laura, etc., well, you know that we are looking at an extraordinary transformation, very powerful, super fruitful, which has the seeds of a problem. The advantages are obvious. What you can or cannot do with a digital profile of a patient is amazing. You can know so much more. You could prevent so much more. You can tailor so much more. And that's just about an individual. Then there's a whole class of individuals. So clearly, this is, in a way, if you like, too tempting. You can do it easily, and you will be able to do that even more and more easily in the future. What happens, however, is that this becomes also, as I said, contains its own problem, a bit of obstacle when it comes to losing sight of the actual patient. Next slide. Privacy, prevention, predictability. These are all features that that the system allows. But if you like, it's a bit of a trap, a feasibility trap. Because I can do it increasingly easily, because that is what everybody asks, well, inevitably, that's all I do. And so from the very first day when there might be some scanning of a patient, through all the many, many, many steps that go all the way through, finally a clinician taking a decision, the patient is seen once. The rest is all about the digital screen, whatever you have in terms of that twin. The eclipse is everywhere, but this affects the medical sector, the health sector, particularly education. What you educate, of course, a student will be a doctor, a nurse, but you educate the twin, the digital twin of that nurse or that doctor. Employment, same story. HR, same story. Retail, pass me the joke, the chemist, the pharmacy around the corner will treat almost at some point only the digital twin, not the person behind it, unless you know the actual person and say, look, no, this doesn't agree with me. I don't know why they give it to me all the time. And of course, the whole world of health. So something is great, but also problematic here. The solution is more of the same. I've been to lots of meetings, and I wish, like anyone else, I discourage everybody from naming people and institutions. So I will not do that. But suppose you are in New York, and there is an amazing hospital in New York that does an amazing amount of work in New York. And the story that you get from the amazing hospital in New York is, we buy so much AI, you wouldn't believe it. Why? Well, to resolve their problem, so we don't have what I call this disappearance of the patient. In what way? Oh, because once we buy so much AI, the doctors will have more time to spend with the patient. And I hope everybody here knows that that is a story. Now, this is the budget of the United States 2022. You can see the sort of orangey slice is 23% of the federal budget, which is almost a quarter. That is insane, given how bad that money is spent. We know that the health state of the United States is not at that level of expenditure. There's a misalignment between how much money is pumped into the system and how much health comes out of it. Having said that, where their money goes? Well, the profitability of medical innovation, AI these days included, expands the market. You can treat more people, not more time with the patient. I can have more patients. You can lower the cost. I can hire less people. You can increase productivity. The same doctor or the same nurse will now see you because he will see you on a screen. And so the story that the eclipse of the analog is solved by throwing more AI at the problem just multiplies the problem. Hence, a bit of a difficulty here, which we can solve. Good design, good thinking, good knowledge, proper way of going ahead, but not by simply thinking the market will solve it. Oh, all we need to do is wait until AI will enable the doctor to see the patient. That is not the road we have taken. The road is more markets, lower cost, higher productivity. How do you do it? Well, you need regulation then. The market is not there to do that. Someone else is, called society, politics. Well, regulation is a mixed bag of good and bad news at the moment. There is a lack and lag of regulation all over the place. Those numbers are from the colleagues at Stanford. As far as I know, are the most recent. They might have one even more recent diagram. The point was, I just wanted to show you a picture. So it's for illustration purposes only, like the tin you find at the supermarket. The whole point is that regulation is increasing, but it's not getting there yet. There's a lot of bills, but we're not really seeing a deep, profound impact in the positive way of regulations on the deployment of AI in the health sector. Since 2016, more than 100 bills all over the place. I like to remind the people outside this room that the world doesn't end in the transatlantic sort of context. There is plenty of the rest of the universe that is doing a lot of work, including about legislation. Overall, however, we're not there yet. We need to push a little bit more. Part of the goal of this conference, as we heard before, is to contribute to the good push for good legislation, for good regulation. We have some. Of course, we have in the United States the executive order. Just wait to see what's going to happen to that now that Trump has been elected. We have the Convention on AI at the Council of Europe, and of course we have the AI Act in Europe. Now, the executive order, of course, is not a piece of legislation. It's more like a set of recommendations coming from the president, and we're not quite sure what will happen to it with the new administration. I have a bad feeling, so to speak. The Convention on AI is something that you can disregard entirely, ignore it. It was meant to do something good. Of course, this is the Council of Europe. For those of you who might not have been reading news about the European Union on a daily basis, of course, do not get confused about the Council of Europe and the European Council. Of course, are two completely different things, inevitably. The Council of Europe is much more inclusive and cares for human rights, mostly only. The convention is without any tooth whatsoever, so do not expect anything more than goodwill, lots of nice sort of statements, but zero implementation. There is no sort of real effective impact. The AI Act, well, it does and it doesn't cover, intersects in a complex way with the current and future medical regulation in Europe. Some people complain a lot about saying there is too much. Other people say, well, never enough. My personal judgment is a good step in the right direction, but many more steps need to be taken. One thing that we need to take away from the table is the idea that innovation or regulation. I hear this always. In fact, I think I spent my last 30 years in this field thinking either or. That is a story sold by those who do innovation. And it's a short-sighted story. It harms them as well. The best scenario, the one towards which we want to walk, is best innovation hand in hand with the best regulation. And for the pleasure of some of you here, I will have to refer to the Zeppelin, of course. No, a great way of going around in the world, and that was thought to be a great innovation until it exploded. And people thought, maybe not. So there's plenty of innovation that is a bad idea, plenty of innovation that needs to be pushed in the right direction because it's a bit ambiguous, and very good innovation that needs to be supported. One of the problems we have today is that we don't have enough good regulation that enables those who have the innovation to step in and implement it. It doesn't take a philosopher. No. I have the possibility of doing X. I don't know whether doing X is right or wrong. If I do something right, no one is going to thank me. If I do something wrong, everybody thinks it's my responsibility. Therefore, I don't do it. As simple as that. The whole medical/health sector is full of these episodes. So we need some good regulations. At this point, you may step back and start thinking, okay, well, the actual problem here is not innovation, it's the governance of all this innovation. So what we have as a main difficulty right now, in these days, is not how many things we could do with this AI, because that looks like magic. You go to any medical convention, and the kind of stuff that they show you, I know you've been there, it's like, wow, can we really do this? Oh, amazing, extraordinary. Well, look, if only you could put this phone next to your eye, I could tell you. So how come that is not happening? Lack of regulations, lack of trust, lack of certainty, therefore lack of legislation, therefore going backwards, lack of decent governance. So the new challenge is the governance. And that's the last bit that I want to tell you about in the next 20 minutes left, possibly leaving a bit of time to Jess. Governance can mean many things, but since Plato onwards has meant at least these two things: control and direction, because it comes from navigating. After all, we are in Venice. So if you are the governor, the Kubernetes of the ship, you can control your ship. You cannot control the weather, but you can control what you are using, and you have a sense of where you want to go. You're not simply going around. You have a plan, and you have some control of the means to activate, implement that plan. From Plato onwards, that's what we mean by governance, and it has been exploited as a metaphor and as a concept in political science ever since. We can rely on that too. So governance as control and direction. Okay, I'm getting quite clear. There's a lot of innovation. We're not doing it because there's no framework. The framework requires governance. The governance is control and direction. But of what? Well, a bit of simplified stuff helps. If, as I know you know, you want to reduce anything we ever do with these things around us, you can do worse than just having a bit of Unix there and say, well, read, write, and execute. That's all we do. In fact, actually, there was a time when I thought that was all I do as a human being anyway. So you either put something out there, you're either getting something from there, or you do something. So I think kissing is execute. That's the way I romantically explain this to Kia, my wife. So I'm going to execute a kiss. Luckily, she's a neuroscientist, so she understands. But read, write, execute, that's the story. That's all we do, certainly with files. The permissions, who does what, when, where, well, those depends on who is in control. But if you control who reads, who writes, who executes, then you are a way, way, way forward in terms of understanding the governance of all this. Once you keep that in mind, and I need a bit of patience, we're almost there. I know it's after the coffee, but allow me for another bit of abstraction, just a little bit more. So the read or readability of something, that includes accessibility, what you do with it, etc. The writeability of that something, including availability, and of course execute, the executability of something, well, they have something in common, the little piece in red, the ability of the system. For the logicians, I don't think there are many here today, but the logicians among us is when we, in mathematical logic, that was my previous life, you speak about the arity of a relation. Remember binary, ternary? Well, you extract the arity and you say, well, how many things does it take to satisfy that relation? 2 also is binary. So what's the arity of the relation 2? What's the arity of the relation 3, 4, 5, etc.? Back to us. What's the ability of that space of data, of the medical space in particular? Well, you can pick up the metric you like, as long as it's numeric. In this case, 0 to 4, it could be 1, 2, 3, it doesn't matter, as long as we share it. So the ability of that space could be 0, so it's completely locked, can't write, can't read, can't execute, 0, throw it away. Something somewhere the CIA probably has it. Or the full. I've been a member of, I was the chair of the advisory board, ethically speaking, of a program to share data, medical data, in Europe that was looking at, not in these terms, but intrinsically at the ability of the database put together at European level for rare diseases. There would be 4. Full readability, writability, executability of everything shared. And of course, he failed miserably after tens of millions of euros. But that's another story. But you can tell that basically the ability of the medical space goes from 0 to 12. Who decides about those numbers? In other words, what happens to the full ability of that digital space? I hope I didn't lost half of you. It's quite simple. Well, there are technical issues, protocol, standards, security, etc. They affect the ability of their space. Legal, data protection, liability, etc. Social, market forces, public opinion, trust. Do I really want to, etc. And therefore, you regulate the read, write, execute, 1, 2, 3, 4, at what level of their space. And can you still get to 12? Do you want to get to 12? Of course, there are also cultural issues. Translation, past analog records. Can I still write, access those records? Structuring, data lakes. They're still part of this read, write, execute. Preserving, shortage of memory, security, cyber attacks. We come to the topic for our conference, the normative issues. Who controls the ability of the data space? And I know I put it in a sort of short version, but there's nothing particularly fancy about it. If the ability of that space in those three terms goes from none to top, whatever your metrics is, it could be even qualitative, none, low, medium, high. Who controls the ability of that data space these days? Especially as we move increasingly towards a private or profit-oriented, which is nothing to be ashamed of, context of medical research. What degrees of accountability for the ability of that space? If some data are no longer available, was there a legal requirement to keep them for 5 years, for example? What levels of fair competition between the different spots of that space in terms of ability? Bear with me, we're almost there. You can synthesize all this in terms of who does and should own the control of the read, write, execute of the medical infosphere, and those who control the questions, as you know, shape the answers, and those who shape the answers control reality. This is a rewriting of 1984. It was present, past, and future. As you can tell, it works pretty well. What values should we protect and promote in this analysis of a space that sometimes, at least in the past, was considered to be public? And today, increasingly, we also understand to be largely private. A lot of the issues that we are facing, I suspect, today, tomorrow, and the day after, will be design issues. Issues of how we shape all those points that I made before, the technical, the normative, the social, the cultural, that make that space, the space of data, and the agents working on those data, the AI, the machine learning, and so on, of one kind or another. There's a, I'm not saying like a happy ending, but something that can be said in terms of, okay, what's the final sort of step? And we're really closing here. Stepping back, we are undergoing a huge digital revolution. It has many chapters. One of these we're discussing during the symposium is AI, but it's not the only one. We need to remember what other chapters have already taught us. This whole book called The Digital Revolution is supporting us in terms of understanding where we live, in what space, in what time, and with what other forces, what other actors and agents around us. The actors are inevitably no longer just governments and national states. Plenty of multimedia corporate organizations have the same power or more, and of course the agents are also artificial, hybrid. So it's complicated, as they say on Netflix. In this complex and complicated space, there is need for more certainty and less risks. What can be done is immense. What is being done, not so much and not so well. Not so much and not so well can be counteracted by having better rules of the game. Better rules of the game means norms. To get the norms, you need the governance. Someone elected, possibly, who decides that's the way we play. I show you some attempts already made around the world, the AI Act is probably the best and only rule book that we have at the moment. More will come, and others will copy from the AI Act. But it's not enough. Certainly not enough to eliminate the do too little and do something wrong that we have in the medical context, but not only right now. I also mentioned the fact that one of the challenges in this whole movement is that some of the problems are generated by the solution. So it's not that we do something wrong, it's in doing something right, we also prepare the ground for some counter effect, to put this more medically. There is an unfortunate side effect that we don't like. The disappearance of the patient, just to put it simply, is probably one of the major ones. This eclipse of the analog, if you like. We lose sight of the individual in order to work only on the digital. Paradoxically, as if that were not already sufficiently complicated, when it comes to control, I told you about the read, write, and execute, but consider that companies and organized institutions, could be a government, could be a supranational institution, when they want to control the digital, they don't control the digital twin. They control the hardware that makes the digital twin possible, that hides the analog. I'll do that again. If you are a national state and you want to control what happens in terms of digital sovereignty, for example, in the medical context, the first thing that you ask is that company must build their data warehouse here. That is physical control. Those cables have to be done in such and such way. Those airwaves have to be regulated in such and such way. In other words, the hardware turn in the control of the digital happens when you elaborate digital sovereignty to control the digital by controlling the physical means of the implementation of the digital. It's an attempt. History is open. We don't know whether it will be successful or not. But at this point, and we're coming to almost to an end, you got these three vectors that are moving all over the place. One, the more digital, the more AI we have, that's fantastic. But the side effect of the vector is that we lose sight of the analog. That's dangerous. Meanwhile, the control of the elaboration of the digital patient, if you like, is controlled by those who should control it, not in terms of controlling the digital or the patient, but controlling the means of production, the hardware that lead to the digital twin. Now, in all this, for example, by limiting the amount of electricity you can produce, maybe I don't allow you to reopen that nuclear plant, or maybe do. That is physical power. Turn off that nuclear plant, there is no electricity, there is no cloud computing, there is no service, there is no digital twin, there is no loss of the blah, blah, blah. So all these variables are what we are facing at the moment. There's a final component which I introduce now and then I close. I said governance is the key. Hence this symposium, which is dedicated not to the technological innovation, and it's not a legal conference where most lawyers are sitting around, how we create and harmonize rules of the game, but has collected experts in the field who would like to see what is going on and where we should be doing, where we should be going. So, broadly understood, governance. What kind of roles do we have? This is the green collars and the last slide. If you ask people, one of the concerns, and it happens often these days, you will see me interviews with journalists here and there, it will be the health of the patient and jobs. Are we going to lose jobs in hospital, for example? Or are we going to see the disappearance of the doctor, of the nurse, inevitably? Or digital twin, who needs 10 doctors, 10 nurses? I need only one, checking 10. Well, actually, this is the right context, but not only in this context. What we're looking at is a future where increasingly the jobs from the little one to the big one will have those features: stewardship, design, care, management. Already now, the United States have mostly jobs of this kind. Nobody works in agriculture. Nobody. 2-3% of the working force in the United States. And virtually almost nobody works in sort of hard industry. Vehicles, if you like. That's another maybe 4 or 5%. So if you take away 6, 7, make it even 10%, which is not true, of people working in producing some stuff that is biological or some stuff that is engineered, 90% of the other jobs are of this kind. They design, they take care, they modify, they improve, they put forward, they remove. In other words, they create something, they take care of it, they manage it, they dismiss it, start again. Stewardship. So, since we have run out of colors, because we had the brown color in agriculture, the blue color in heavy industry, and the white colors in services, well, the only other color left seems to be obvious, green colors. So, to conclude, the responsibility of this and the future generation as green collars will be to develop the right governance that will put in place the right framework to make sure that innovation, the best, and regulation are the best, will enable the medical sector to step forward and do what it has always done: take care of humanity. Thank you. Now, I invite to join me Jessica Marley for her framing the debate.
Where is the
Slide point.
Thank you. Okay. Hang on. Is this clicking? Okay. Can you put a slide? There we go. All right. Thanks. Hi, everyone. So if you don't know me, I think most of you do. I have been in email contact with probably all of you, and you're probably already sick of my name, but I am Jess. I'm postdoc at Yale University in the Digital Ethics Center. And apparently, as Luciano has just told you, my job is to do two things. It's to wake you up and to frame the debate of the next 3 days, and therefore to make sure that we don't fail. So I have absolutely no pressure on me whatsoever. Come to Yale, be my postdoc, it will be fun, he said. But anyway, this is what we're going to talk about. So global health in the age of AI, why, how, and who for. The why is highlighted for a reason. So if you fall asleep, the TLDL, the too long didn't listen, the only word I really want you to remember is why. And then the second part of it is global. Sometimes we have these conversations around AI and healthcare, and they're incredibly national. We focus really, really small, where we want to talk about the global picture. Just on a small scale, I am a British researcher working in America in a conference in Italy. We definitely don't work on a national scale anymore, so we should focus on the global. So just to tell you where we're going, there are 4 areas of things I'm going to talk you through. I'm going to talk you through the opportunity, but I'll probably spend the least amount of time on that one, because if you're in this room, you already know, most likely, the opportunities that are presented by AI in healthcare. I'm going to talk a little bit about the implementation gap. So you already heard a little bit about this, but basically, why are we not getting this stuff right? Why have we got an enormous amount of AI being developed in elite universities and research institutions and not a significant amount operating on the front line? I talk about the requirements, about what we need to get things right in order to close that gap. I'll probably say the word infrastructure in that section about 300,000 times, so apologies for that in advance. And I will also talk a little bit in that section about some of the ethical principles, just to fill in the gaps that we would have had from Effie, where she'd be able to join us, and to lead more into Ravi's talk afterwards. And then to bring back to my point about the why being the highlighted word, I'll end on the bigger picture. And that's really the exciting bit, and that's why we're all in this room for the next 3 days. So first, just to talk about the opportunity. Oh, by the way, I'm really proud of all my robots in this presentation. They're my favorite thing. So again, if you remember on the why, focus on my robots, and that will make me really happy. So what is the opportunity with regards to AI in healthcare? There is an overarching line that follows this sort of idea that if we implement AI into the healthcare system, we can achieve the quadruple aim. The quadruple aim is improve the population health, improve the experience of care, reduce per capita cost, and improve the experience of staff. Now, it used to be the triple aim. They only recently added the improve the experience of staff as a sort of afterthought. So the fact that we used to have the triple aim and improve efficiency by reducing per capita cost and improving the experience of care came before improving the experience of staff tells you pretty much everything you already need to know about this narrative and what I think about it. And it also points back to Luciano's point around why this idea that we can suddenly use AI to make clinicians do less is definitely a story that we like to spin rather than a reality of what we are currently designing. But what sits underneath this overarching aim of using AI to create the quadruple aim is this sort of two symbiotic ideas. The first one is that if we intervene earlier and create more targeted interventions, we will have better outcomes for patients more successfully. So this is what some people might have already heard called P4 medicine. Other people might have heard it referred to as systems biology. But the idea is by taking into account all of the data about a particular person, whether that be their genome, whether it be their phenome, so their outside presentation, what they eat, how much they interact with the world, their social life, absolutely everything, we can work out what they are likely to become unwell from in the future. We can tell them, you're going to become unwell from this, so we can prevent it. And we can then treat those future illnesses as well as ones that are already affecting the patient in a more targeted way. So the line I have used before sometimes is that this is presented as a main means of making the person, the patient, more centered, to make it more personalized. The sort of challenge I want to throw out to you is that this is actually like targeted advertising for medicine. It's putting people in boxes and then thinking which box do they match up with, and then making sure that we get the right treatment to the right box. There are other ways of thinking through what personalized medicine might actually mean, which I'll talk a little bit about in the bigger picture at the end. And then this idea is essentially that because we have intervened earlier, the sort of treatment, prevention is better than cure line, is that will therefore be cheaper, and that's what makes it more efficient and effective. And then the second part of that efficiency and effective line is that we can use AI in the back end as well as the front end of care. So we can use it to make sure that we are doing things like discharge notes more quickly and staffing hospitals better, et cetera, et cetera. I personally think that that's where we might get a greater advantage from the use of AI in healthcare than just from the front line, but it's less sexy, it produces less headlines, so it gets less attention. Nobody really wants to write a newspaper headline that says, hey, discharge notes now take 3 seconds instead of 10 minutes. That's much easier to say a clinician, an AI algorithm can now diagnose better than a clinician. So to be more specific, these are the kinds of things that appear in the policy documents that are produced by national governments. So, at the top, we've got Australia, Canada, India, and the UK saying things like, we want to use AI to improve clinical efficiency, healthcare availability, and access. And down at the bottom, you've got India, the UK, and the United States saying things like, we want to use AI to overcome staff shortages. And in the middle, you've got a range of countries saying they want to better manage the increased volume of chronic disease. The policy documents of international governments are full of these types of statements. But what I really want to highlight is the fact that this doesn't say how AI is going to achieve any of these things. It just says we want to do it. We want AI to do this. We want AI to solve all of our problems. So you could, because it doesn't say it doesn't say how AI is going to achieve this. In most of these policy documents, replace the word AI with the word magic, and the sentence would still make the same, it would still make sense. So we just don't have an awful lot of specificity at the policy level. To be more specific, again, about what they do say they want AI to do, still not saying how they want AI to do it, but they want AI to achieve those goals by, for example, enabling more targeted treatments for specific conditions or increasing the speed and accuracy of diagnostic pathways. So that's just to sort of prove that my point around that overarching narrative of using AI to achieve the quadruple aim was not something I dreamt up in my sleep. It is something that appears in an awful lot of high-level national documents. The point around the fact that this doesn't say how we're going to do this is particularly relevant in this last one about the speed and accuracy of diagnostic pathways, because what we see very often in the space of AI in healthcare is, oh, we can get an algorithm and look, it can diagnose people, it can recognize images better than a human. Yeah, of course it can. Look, image recognition is a solved problem in the space of AI from a technical perspective. Every time you have to prove you are a human by clicking on a light, you are training an algorithm to recognize an image, which is a weird irony that we don't need to discuss right now. But what we don't necessarily know how to do is how to implement AI in the entire care pathway in order to make sure that it is efficient from start to finish. So an example I have given before is breast cancer. In the UK, breast cancer screening is the most expensive prediction screening that the country runs. It's because it is offered to a very large number of people, and every single breast cancer scan is read by 3 humans. It's read by 2 clinicians, and if those 2 clinicians don't agree, it is then read by a 3rd clinician. It is a phenomenally expensive service to run. There are 2 companies that have regulated medical device algorithms that can recognize breast cancer more efficiently and more effectively than a human. They work phenomenally well. What we have not quite worked out yet is where does it make sense to implement that reading of the scan? Because if you read too early, and you can have an algorithm that's just reading hundreds of thousands of scans all at a time, it never needs to go to sleep, but we haven't increased the capacity of the system to treat the people, it's not necessarily clear that we have done anything better, or in fact, what we have caused is psychological harm to those huge number of patients who now believe that they have a potential risk of cancer, and it's just sitting like a time bomb in their head, and yet they don't have access to care. So that's why we need to say the what as well as the how. This is not, as you've already heard a little bit, this is really not just empty words. This is turning into hard, cold cash. The amount of money that is being funneled into AI in healthcare is ridiculous. Everybody who knows me keeps telling me that my idea of what is a huge amount of money is kind of skewed, but I think this is still a huge amount of money. So if you have in the UK, the previous government, before we switched, they spent 123 million on the AI in Health and Care Award, 21 million for the AI Diagnostic Fund, 30 million for the Health Technology Accelerator, Health Technology sort of Review and Acceleration Fund. The Canadian government has spent 49 million Canadian dollars on the digital health discovery platform. You've had the Singaporean government sing 180 million Singaporean dollars in AI, including healthcare. So just to give you why they think this is, and to just prove that, again, that point that's around the efficiency and point that I made at the beginning, it's not something that I made up. You saw Luciano put the budget up from 22 of the US. The US Bureau of Economic Research estimates that AI adoption can save between 5 and 10% of annual spending on healthcare. So we're talking about really, really, really significant amounts of money being funneled into this space. And yet there is a really significant implementation gap. What do I mean by the implementation gap? Well, the fact is, at the moment, AI is in this really awkward space that nobody wants to be in. If you're ever pitching a research project or writing a grant, the space you want to be in is under-promising and over-delivering. AI is doing the exact opposite. It is over-promising and under-delivering. So we have this enormous amount of hope surrounding AI. If you can think back to 2 seconds ago when I was putting up those statements around what do governments say they want to achieve with the use of AI, the number of promises in there is huge. It's everything from making sure that we have predicted who is going to not turn up to appointment to make sure that we have the most efficient appointment times, all the way through to we are going to predict the onset of every single possible disease ever. And yet, it is not having the impact that we want on the front line, despite all the hope, despite the amount of money that's going into it. And we have known that fact that there is a really significant problem of moving from the lab to the clinic. So there is a really great amount of research being done in elite universities and research institutions, in innovative companies, but the rate at which that is moving into hospitals, into primary care institutions, into community care things is really small. So to give you 2 numbers just to sort of have in the back of your mind, Actually, I'll give you 3 just to be fair, I guess. The number of things, sort of algorithms, predictive algorithms that are moving from research into the clinic is less than 2%. So less than 2% of the algorithms that are developed and that are published in research papers actually make it into clinical care. The number of prediction models that are in healthcare that are actually running on machine learning or AI rather than just basic bog standard statistics is about 10%. The other 90% of sort of clinical decision tools or prediction models are just basic statistics. They're not using anything that is even remotely close to AI or machine learning. And the third number I'll give you is the FDA, so the Food and Drug Administration in the US, which is the body that regulates medical devices in the US. The equivalent in the UK is the MHRA. They have approved just over 900 medical devices that use AI. The number of clinical trials, or the number of, so not clinical trials, the number of things in development is like 4 times that. So we're just really missing that move from the clinic, from the lab into the clinic. In fact, sometimes it is called not just the implementation gap, it is referred to as the algorithm graveyard, which I quite like. It makes it sound a bit spooky. But there are all these algorithms just dying, and they're never making anything. It's also that there's a narrow range of solutions. So people are really hyper-focused on developing AI for things that are sort of low-hanging fruit. They're fairly obvious sort of medical problems to go after. Like I just said, breast cancer. Breast cancer is one. There is an absolute glut of companies trying to tackle and diagnose breast cancer because breast cancer is a big, wide, huge problem. But breast cancer is also something that the healthcare systems globally already know how to deal with. They might not be super fast. There might still be some people who are diagnosed, unfortunately, at stage 3 or stage 4, and we want everyone to be diagnosed at stage 1 or to have prediction. But it is known how to do it. Where we are going to see the most benefits from AI is by targeting the areas of healthcare that we don't already know how to deal with particularly well. And yet the focus is skewed towards the obvious problems. And that is partly because you don't get clear signaling from policy. You get these very high-level statements rather than very specific, these are the actual problems I want you to go after. And then the last reason why we have this algorithm graveyard is that there is really, really, really poor quality evidence. Medicine is a highly regulated environment for a reason. The line somebody once gave me is we can't move fast and break things in healthcare because we break our people. And that's true. We don't want to break people. We have seen huge numbers of medical scandals in the past when we have tried to implement new technologies too quickly without thinking through all of the implications. And the sort of solution that we have come up to with this problem is to generate high-quality evidence that it actually works. In healthcare, we are not seeing this. Instead, there is a conflation of statistical accuracy and clinical efficacy. What we see is an enormous number of very clever people, and these are people who I work with on a day-to-day basis, so I'm not being dismissive, but they publish algorithms and they say, oh, look, my area under the curve value is so high, I'm so cool, and then they never follow up to say what that actually meant for healthcare. It's just saying that I have a very highly predictive and very highly accurate algorithm is not the same as saying I have a highly effective treatment for healthcare. We don't have the types of clinical trials, the types of high-quality evidence that we expect for every other type of medical device that we intervene with. And health technology assessments are also the same problem. And we also don't have the economic evidence. So just to come back to that whole point around this line that AI is going to make things more effective, more cost-effective, there is no known methodology, no agreed methodology for working out the health economics. So what is the benefit economically of introducing AI into healthcare? So this throws the whole system into whack, because the way that we would normally do a healthcare technology assessment is you take original drug or original device, you compare it to the new one, and you say, is it more effective, and is it more effective and clinically efficient in terms of cost? And we don't know how to do that for AI. So hence, we have this problem of everything dying in the graveyard. Well, I guess if it's in a graveyard, it's already dead, but whatever. So what is the holdup? You already heard Luciano refer to this problem of complexity. This is a framework, so it's the NAS framework, which is developed by some colleagues back in Oxford, specifically by a lady called Trish Greenhalgh. And it essentially argues that the higher the degree of complexity in each of these areas, the more likely a technology implementation program is to fail. And the thing is that when you do AI through this system, you get the fact that it is highly complex in every single one of these domains. So just to run through them really quickly, because otherwise you're going to get super bored of my voice if I spend an enormous amount of time explaining each one of these. Condition, a simple condition according to the framework, is when we know who is most likely to be at risk, what is the most effective treatment, and it is intervening in the moment. AI, as I've already just said, is sort of throwing that whole logic on its head. It's about trying to challenge the assumptions of causality. So find out who, of different types of diseases, what are the different factors that we don't already know. So therefore, we don't, by definition, we don't know who is going to get sick from these diseases because we are trying to find it out and we're trying to blow the whole picture open. We don't have a ground truth. So we don't, because we are therefore having this whole big soup, we don't know what to expect. So I don't know whether I'm supposed to expect a population with a 15% rate of diabetes or a population of 30% of diabetes. So it's really highly complex from that perspective. And we don't have a clear target. We don't know what we're trying to achieve necessarily through the implementation of these technologies for the specific conditions. Next, we have technology. So the technology here means two things. It means the AI itself, and it means the legacy infrastructure. See, I told you I was going to say infrastructure too many times. That was number one. It's talking about legacy or missing infrastructure. So first of all, AI itself is complicated. Or complex. I'm not going to say too much about that because everyone in this room has probably heard it, and you'll hear it again over the next couple of days. But it self-learns. There's an enormous amount of variables involved. We don't necessarily know what they are. This is the black box problem, etc. So it itself is complex. The infrastructure that it needs to run on, that was number two, is also really complicated in itself because we need to have access to real-time data. It needs to be accurate. It needs to be updated in close to real time. We need to know when to fire alerts. So do I tell them at this point in time or that point in time? We need to know how the clinician interacts with the way in which the information is presented. And then there is the fact that most infrastructure, that underlying layer, that was number three, for those who are counting, is really, really, really broken. So to give you the examples that I know best, which is from the NHS in England, you will often hear this thing, oh, NHS has got the best opportunity for capitalizing on AI in the whole world. Every single country says that about themselves, by the way, but the NHS really likes to hone in on this. And then you go into a hospital ward in the NHS, and there will be one computer on wheels from the 90s that has a broken keyboard that is being shared between 3 wards, and nobody knows where the plug is, and there are 17 different electronic health records being used in one hospital. That is the problem with legacy infrastructure. And then you take the flip side of the coin, where you maybe go to countries in, for example, the global south, that have not that legacy infrastructure problem, but they have no infrastructure. So we have this sort of challenge of where do we get it right? Then the value proposition. So that was my point with regards to clinical efficacy evidence and also the economic evidence. We just don't have it, so it's really unclear exactly what AI is supposed to be benefiting people from. So the value proposition is also complex. And we also don't know, and this is just a sort of a trailer of what I'll say in a minute with regards to principles. We don't know the could versus the should. We don't know the value proposition in terms of just because we could do all of these things and we know that AI can do all of these things, is this definitely what we want to be doing with all of this AI? And this causes complexity in the domain of adopters. Adopters being patients, clinicians, and hospitals. The willingness to adopt is really contextually specific. It is not just a flat line. People have a number of different conditions that they want to be in place before they are willing to adopt AI into their healthcare system. And most of those conditions are conflicting. Some of them are not known, and some of them are impossible to meet. And what do I mean by conflicting or impossible to meet? The clearest one is that healthcare data, people's willingness for their data to be used for research is normally very high. They're like, yes, please, please, please use my data to help cure cancer. If and only if the person curing the cancer is a research institution or a healthcare system, not a private company. People get very angsty about the idea of their data being used for profit. And yet, the vast majority of the people who are developing these tools are coming from private companies. And so you already have a conditional conflict in the middle of those adopter. And then there's the wider context. The wider context is really what we're in this room to discuss, but there is an unstable environment, there are geopolitical challenges, there's a huge amount of competition, and then there is this whole debate, which we have already heard, so I won't repeat, about regulation versus innovation. But essentially, the whole space is moving. There is no certainty. Medical device law is changing, AI policy laws are changing, data protection laws are changing, global powers are changing, there are shifts in dynamics. And we don't know how to work as a global community and at the same time maintain national sovereignty or national level competition. A clear example of this is that every single country wants to build their own. Oh, we are going to be the most innovation-friendly country in the world when it comes to AI, and then we're going to build everything ourselves. Not every single nation-state has the resources inside itself to deliver and develop the best algorithm to treat every single possible disease that has ever existed and ever will exist. There is a greater need for collaboration, and yet we don't know how to create the environment for that. So there is an enormous amount of complexity in the wider context. Why does this matter? Why does it matter that things are going slow? Should we just not care and just be patient? Well, there are 3 reasons why we should matter. The first one, see, this is my favorite robot because he's frozen, is that there are chilling effects and that we may have a health AI winter. So people who have known of this idea of the AI winter before will know that these things occur when there is over-expectation and under-delivery, and then the investment in AI drops off. So all of that money that I showed you earlier just disappears. That's what an AI winter is. We are going to hit that with health if we do not start seeing the actual sort of results from a clinical perspective, not from a research perspective, of what we expect AI to do. And then there are chilling effects. A chilling effect is essentially if we do something too quickly and we get it wrong, and then everybody gets turned off. They're like, oh no, that was really bad, that was really scary, we don't want to do that again. So we need to have the environment in order to make sure that we don't have chilling effects and that we don't incur in a health AI winter. Then there's the fact that there are wasted funds. Healthcare globally and nationally is a resource-constrained sector. We do not have an infinite amount of money. Every single thing we spend on AI is money that we are taking away that we could spend on a different solution, including more human solutions. And so if we are only funneling money into AI and it is not delivering, we are wasting funds, not just in terms of non-delivering in terms of AI, but we are wasting funds that could have been spent on other things that we know are more effective. So we also, this is another reason why it matters that the implementation gap exists. And then the third reason is opportunity cost. So I put in the opportunity cost one because otherwise people tell me that I'm a killjoy. I'm really not. I am very enthusiastic about the possibilities of AI for healthcare. I just think it's important to be realistic. But we have significant opportunities to save and improve lives when it comes to AI. If we don't close the implementation gap, we are missing those opportunities. And from the perspective of human rights, where we have this sort of everybody has the right to health and everybody has the right to benefit from science, if we are missing on those opportunity costs, it's a really significant harm. So we have to also remember that. So how do we start closing the implementation gap? To put this in design terms, because we've already heard that design is everything, what are the requirements to get things right? In order to think through the requirements, and this is really where I'm going to start talking about the point of the next 3 days, we have to get beyond siloed thinking. So siloed thinking is necessary, but it's not sufficient. What we tend to see in the AI for healthcare space is people talking about one of these 4 blocks, but then not talking to each other, and then assuming that they exist independently of each other. So you might get people talking about technical feasibility, so what type of algorithm is the best for this particular type of thing, or what type of infrastructure do we need, that was number 4, do we need in order to deliver it. Then there's also social acceptability. So this is people talking about what are the social expectations? How do we incur the social license? How do we make sure we don't hit those chilling effects that I spoke about before? Ethical justifiability. So that is that whole could versus should thing, and I'm going to not talk too much about that in a second because you're going to get more in a minute. And then there's also legal compliance. Now, what I want to sort of stress is that all 4 of these things are not one. They are all additive. They all influence each other. technical feasibility is circularly influenced by legal compliance, which is influenced by ethical justifiability, which is influenced by social acceptability. Everything is influencing each other. And we won't close the implementation gap unless we start to shift the mindset, that was a difficult thing to say, to start thinking about these things as additive rather than silos. So to just give you a quick example of what I mean by this, and I'm really going to fly through these next few slides because you will hear more from Ravi. So often the way in which we have conversations about the law when it comes to AI is as if it's the ceiling. This is what we absolutely can do. This is the maximum, right? We must hit this level of clinical efficacy from the perspective of a medical device, and then that's the sort of top. What I really want to stress is actually the law is the floor, not the ceiling. The law is telling you the minimum. This is what you absolutely have to do in order to be compliant with the law. You can go above and beyond that to do things that are more ethically justifiable and more socially acceptable, and that you are therefore less likely to hit those chilling effects. The reason I say this is that there are differences between the law and ethics. So the law will tell you can and cannot. Ethics will tell you should and should not. The law is kind of rigid, and as you already heard, it's a bit slow to adapt, whereas ethics can be flexible and contextually specific. The laws is sort of the minimum of acceptability, whereas ethics is really talking about social license. To give a sort of real example of where these things two differ, there was a hugely well-funded research program in the University of Cambridge, and I'm not just picking on Cambridge because I'm hugely biased towards Oxford. This did actually happen in Cambridge. They had a big research program called Spectrum 10K. This was supposed to be linking up electronic health records and genomics using AI in order to identify the factors associated with ASD, autism spectrum disorder. They were legally compliant, and they had ethical approval from the university. What then happened was they went public with this project. It had a website, they had a huge big launch, and there was a massive backlash from the autistic community. They basically pushed back and said, we don't want this. What you're trying to do is eradicate our existence, whereas we actually want you to be talking about how and doing research in how you make it possible for people with autistic spectrum disorder to live in a world that is not designed for them. And the project was scoped. This was a well-funded project. And so that just shows you why you have to have the law and the ethics, and then you also have to think through social acceptability. Because it had absolutely everything. Otherwise, it had all of the coulds, but it failed on the should. So what do we mean a little bit more in terms of ethical justifiability? Typically, you see this translated into these bioethics principles, and they are talked about as if they are just ethics. We only have to do ethics, whereas actually these are all technical and legal and social as well. But the four most common are beneficence, non-maleficence, autonomy, which is now bracketed also with explainability and justice. And as you will hear from Ravi in a bit, these have also now been translated into 6 principles, but which are used by the WHO. They have slightly different wording, but they're all essentially the same. For example, it says protect human well-being, which would fall under beneficence, and it says protect autonomy, which is obviously there, but it also says enhance transparency, which is under autonomy. I won't read you the words because everybody can do that for themselves, I hope. But so just to highlight how these things link to those other 4 things that I was talking about. Beneficence is really about what is the expected outcome. So that was my point around not conflating clinical efficacy with statistical accuracy. We want to know what is the outcome we are expecting to achieve for the patient, for the healthcare system, and for the clinician by implementing this algorithm into the care pathway. We don't just want to know whether or not it is 90% accurate. That comes from medical device law. It also comes from social acceptability. So what do we think is socially acceptable? What are the types of things that we are happy to delegate towards AI? Then you have other questions about who was the decision. So this was the point around questions, who gets to ask the questions, who was the person who decided to design and develop that particular algorithm, all the way through to questions of like, how much surveillance are we willing to accept? So you see, beneficence, all of these principles, I'm going to show you all of them just to make sure that you're really bored and fail on my first point around keeping you awake, are very deep. They're not shallow. There are an awful lot of things that sit within them, and that depth is where we see the overlaps between social acceptability, legal compliance, and technical feasibility. Because technical feasibility is also related to expected outcome, which is also related to the law. Told you I was going to do all of them. So then we have non-maleficence. This is eventually everyone's favorite one because it's the one that people are most familiar with because it is linked to the Hippocratic Oath of essentially do no harm. So the questions that sit beneath non-maleficence then are, does it work? Who does it work for? This is something, again, you will notice I've not said the word bias an awful lot in this conversation yet, which is unusual in a conversation about AI, health, and ethics. There is a reason for that. It's partly because you will hear about it a lot more, partly because I think it is overly simplistic. Who generated that evidence? Did it come from a private profit-driven company? Did it come from a research institution? What's the value for money? I've already talked about that. How much sharing is too much? This is a bit linked to that point about over surveillance. So again, all of those questions have links with technical feasibility, social acceptability, and legal compliance. Autonomy. So this one, again, people are slightly more familiar with because they mostly associate it with consent. So people think that the way in which we uphold autonomy in a medical context is by getting informed consent from the patient and shared decision-making. Does the patient understand what is happening to them? What the problem is in AI space, and this is where we start to see the overlaps again, is that that model is broken in two ways. First of all, it's broken in the sense that we don't necessarily know what is happening in the algorithm AI, aka the black box problem. So how do you consent to something that you don't necessarily know is working? And where do you get consent? Do you have to get consent for every single time AI is used in a care pathway, or only at the point it is used in an intervention? Do I need to also get consent if AI is using my medical notes, for example, to preemptively tell my clinician what I might be in the appointment for? So that's point number one in way it's broken. The second way in which it's broken, and the way in which autonomy is really challenging in the AI space is, as you have already heard about the eclipse of the analog, we are not diagnosing physical people, we are diagnosing their digital twin. So everyone's data is flowing around in space, and that is being used to direct their care. People have an increasingly limited amount of control over that flowing around in space. So that has a damaging effect on psychological integrity, or this idea of self-integrity, which is essentially, do I understand the factors that are controlling my life? How do we consent to that? We don't know. And then privacy and the therapeutic relationship also sit within there. Privacy is, again, something that too many people are too readily familiar with, so I won't bore you to tears on it. But it is primarily a legal and a technical problem, even though we talk about it as an ethical context. And then there's the therapeutic relationship. If we have created a whole entire governance system around healthcare, which is primarily predicated on this idea that you have a clinician and a patient, and now we have a third person, we have a mediator, which is mediating that relationship, which is an algorithm, do we know what that really looks like and what it means? That is a should problem. We know we can technically do it. We know it is legally allowed, but is it socially acceptable? And is it socially acceptable in all contexts? It might be perfectly fine for some people in some cultures in the context of diagnosing a disease or helping manage a long-term condition, but completely unacceptable in the context of things like end-of-life care decisions. We just don't know. And lastly, justice. So this is the one that everybody loves to talk about in terms of bias. Do we know that the AI works for every single type of population? Does it work for every single type of ethnicity, every type of gender? But there are, first of all, multiple types of bias. Bias is not just the obvious ones. It is not just ethnicity and gender. It is also the intersectionality. And that is really where we see bias problems in healthcare, is from that intersectionality perspective. And it is so ingrained that it is almost impossible to undo, because it is inherently present in the data. And all of these lovely debiasing technologies that we have come up with that look for the really obvious examples of bias are not looking for those points of intersectionality bias. And it is also not just bias, at least not just bias in the obvious way. There is also things like latent bias, which is bias arriving later in the pathway. So you can have something that is unbiased at the point of deployment, and it becomes biased over time due to things like data set drift. But there is also outcome specificity bias. So this is when you basically target the wrong thing. So remember what I said about the outcome. A really clear example of where this went wrong is there were 2 hospitals in the UK that were sharing an algorithm that they had developed in order to do automatic triaging of people who have been admitted to hospital or come into A&E with pneumonia. They wanted to see, can we identify who is most at risk and get them into the care pathway quicker or send them home? The first hospital that did this, the algorithm worked perfectly. The statistical accuracy was great. They sold it to the second hospital. The second hospital, after a couple of weeks, started to realize that what the algorithm was doing was telling the hospital anybody who is admitted to pneumonia with a pre-existing lung condition, for example, asthma or COPD, should be sent home. They are the least risk. Anybody with any clinical knowledge will know that that makes no sense whatsoever. What it was that in hospital A, there was a policy in place that said anybody who is admitted to the hospital with pneumonia with a pre-existing lung condition should be immediately sent to the ICU. They should immediately go into intensive care. So they got better treatment, and therefore they had better outcomes, and the algorithm had missed the middle. They had just learned that these people are at lower risk, and so we can send them home. That is a different type of bias that we don't see talked about. Then there is a difference between equality and equity. I'm going to talk about this in a second, so I'm not going to dwell on it. There are concepts of sharing resources, and there's the digital divide. The digital divide is not just about who has a device. We can give everybody in the world a device, but we can't necessarily solve things like that. There is a significant variability in digital health literacy. People with lower levels of digital health literacy are more vulnerable to misinformation. They are more likely to look for their health information on social media, which is more likely to be affected by algorithmic manipulation. So justice is more complex. Then there are problems with the principles themselves. Principles are very highly abstract. They encourage an over-focus on technical fixes, like I said, looking for debiasing techniques in data sets, and they miss the bigger picture. They also don't scale. So those principles that I have just spoken through, they are bioethics principles because they were developed to deal with one-to-one relationships of one person with one clinician. Most of the algorithmic harms operate at a group or societal level. Those principles do almost nothing to help us think through the implications of group and societal level harms. So we have to think about how we translate from the what to the how. So if we start thinking about technical feasibility, this is where we start to get things in terms of requirements. We talk about robust information exchange. So how do I make sure that this piece of information about this patient is recorded and is sent to this person at this point in time? How do I do that in a way? Essentially, it's talking about the 5 rights: right person, right information, right time, right format, right clinician. Social acceptability is a thing then about epistemic certainty. How do we know the thing is doing that we think it's doing in a way that we want it to do it to target a problem that we want it to target? Ethical justifiability is about thinking about actively protecting our values. So those values in the NHS would be things like patient centricity, free at the point of care, and available for everyone. But those values are different depending on your cultural context. And then we will sort of talk about autonomous staff. So you will hear later from people who have far more expertise on me about the liability problem. But essentially, how do we make sure that the clinician, and do we even want the clinician to be the final decision maker, or are we comfortable with delegating the final decision to the algorithm? And then legal compliance is about validated outcomes. Do we know that it works? And meaningful accountability. Do we know who to hold account if something goes wrong? Once we know these requirements, you can start translating them into policy directions that start solving them, that start solving that implementation gap. So again, I'm not going to read all of these because that will make everybody cry. But just to give you a couple, I'll do the front and the end. So robust information exchange, which remember is technical feasibility, is about things like making sure we have user-friendly electronic health records. Are we recording the right information at source in the right format in the most appropriate way? It's also about making sure that there's a competitive market. We don't want massive vendor lock-in in the healthcare space, where one company goes in and owns all of the electronic health records of everyone in the whole country, or in fact everybody in the world, because that has an increasingly locking effect on the type of information that is recorded at source. So we want a competitive market. And at the other end, in terms of validated and outcomes and meaningful accountability, We need to have systems in place that encourage meaningful model development. So not just about the end goal, what variables are we selecting, why are we selecting them, all of this type of thing. Remember, anybody who tells you that we don't have control over the types of systems that we are developing are big fat liars, and they have ulterior motives. We have design control if we want to take it. And then it's also about thinking through things like medical device law, liability. And the last point on that slide is the most important one, which is auditability. So we want to be able to audit the entire pipeline, everything from who made the decision to develop the algorithm in the first place, all the way through to how is it operating in real practice. The issue with this is telling me I have 40 seconds, but I have 5 more minutes because we were going to 1:45, is that there is a bigger picture. None of this that I have just told you about is solving or thinking through the big questions. Remember my TLDL? Too long, didn't listen? The question about why? This is the point that we are now getting to. Thank goodness everybody can breathe. We need to think about what we are wishing for. We have to be very careful about it. At the moment, we are focusing on the wrong level of abstraction. We are too narrow. Everybody is looking at the ground or focusing on themselves, or if you know the sort of idiom, it's navel gazing. They're only focusing on their own problems. But actually, healthcare is a global problem, and AI is a global solution. And we can't solve it by focusing solely on national flaws. To give an example, that whole slide I just presented about justice and bias, and saying it's not just about bias, it's about equity versus equality. Equality is everybody has the same. Equity is everybody gets what they need in order to achieve the same outcome. Those two things are different, and we have to solve that on an international scale, on a global scale, because otherwise we miss problems that are really obvious. For example, when companies, I won't name names in case I get sued, come and get kicked out of countries like the UK and the US because they have too stringent data rules, then they go and move to, for example, randomly picking it, Rwanda, and decide to build the electronic health record for that country. That is not a justifiable or an equity-based solution. That is data exploitation, because that country is not being given the same advantages as the original one. So hence we have to think of this as a global problem, not a national one. And these are only half the requirements. The ones I've just spoken to you were only half the problem. They are only talking through what we want to do and how we want to build it. They don't tell us what we want to achieve. So what is actually the whole point? We've all just sort of dived into this healthcare space and been like, healthcare has got an enormous amount of data, we can build AI, it can do all of these fantastic things, but what's the end goal? Do we really want an end goal that is primarily focused around efficiency? Probably not. And the reason why we've got sort of misdirected and focused and forgotten to ask this question, oh, this was telling us what we must be careful what we wish for, is because of who we have left in charge. We are outsourcing too much power and giving too much power at the moment to the technical epistemic community. So these are the people who build the algorithms. They have wonderful intentions. They do not necessarily have the understanding of the complexity of healthcare itself. We need more unicorns. We need more people who move between those two communities, who move between the community that talks about healthcare and normative transformation effects and what it is that we want to achieve, who also talk to the technical community, who do that bridging and that additive point about what I said. And that's why we're all in this room. Because the reason this matters is that there are different underlying assumptions from these two different communities. The technical epistemic community thinks that all we are doing is moving from paper to data. The people who are in the normative world know that we are redefining and redesigning what healthcare as a concept means, and that is a bigger shift than we have potentially paid attention to. So what can we do about this? And this is my last slide. Everybody breathe. We can think about generating evidence, so making sure we know what is happening and making sure we are paying attention to it. We can develop theory about what is happening and what we want to achieve. And we can pilot solutions that focus on those 4 bridging gaps, and I think on the additives, not just the silos. So really, when we are in this room, and as Luciano has said, in the conversations, when we have coffee breaks, when we have dinner, these are the types of things I want you to be thinking about. Think about the why, what do we want to achieve, who do we want to give the power to, and these 3 things of what we can do as actions. And that is it, so thank you.
Thank you, everybody. Thanks for inviting me to chat here. So I'm Ravi Parikh. I am a medical oncologist in Atlanta, Georgia, in the United States. And so I wanted to take some of the principles that were mentioned by Jess in the last talk and give a little bit of a perspective of how we might implement them from both a clinician, patient, and health system viewpoint. And I think when we think about the implementation of some of these broad principles of ethical AI, we might realize, one, where they apply, and two, where there are significant gaps that we ought to be addressing. And I hope to make this argument that the way that we ought to be addressing them is not by coming up with more centralized ethical frameworks, but rather by giving standards for local self-governance of individual algorithms that are being applied. And I'll try to hopefully convince you by the end of the talk. So these are my disclosures. I have a number of grants from both federal and foundation-related awards, and then interact quite frequently with largely companies that are trying to come up with early-stage AI tools where some of my research applies. So that's a little bit about my disclosures. So in terms of agenda, I want to first walk through some of the ethical AI frameworks that you heard about last talk, in particular giving some examples of how they apply in the health system context, and give some case studies about how real-world deployment really pushed the limits and strained some of those ethical frameworks through some edge cases. And then I'll close with giving some potential standards for local governance that hopefully we can get some feedback on as to whether they help or don't really move the needle enough. So I think this is the sort of upshot of the talk. So most ethical guidelines kind of fall into this soft law framework whereby they provide a series of frameworks but don't actually hold individuals or health systems or clinical clinicians to account. And so soft law ethical principles, I would argue, are plagued by low uptake and poor translatability to the typical end users that we think about. These broad tenets of guidance have fuzzy edge cases that may decrease buy-in if they're not addressed. And I would argue that the way to address them, as I mentioned, is through promoting self-governance and local accountability through actual frameworks and not just saying, hey, this isn't covered by an ethical standard, do what you want with it. So maybe just to set the stage, there's been quite a promulgation of global AI governance frameworks. I was really hoping that Dr. Vaiana could speak today because she's not only been involved in the development of these frameworks and has helped to come up with many of them and is cited on many of these WHO frameworks that have come about, but also would have given quite a good, some good insight into how they were developed and how the sauce was made, but I'll try to do my best. So international organizations have been key actors in the global governance landscapes, and if you'll take a peek around, you'll notice that organizations like not only the WHO, but UNESCO, the OECD, the United Nations, the European Commissions, have all come out over the past, not too far away, over the past 3 to 4 years with frameworks for ethical deployment of AI. Now, many of these are cross-industry, but the WHO has been health-specific, and you can see some examples of WHO frameworks that have been released just since 2021, starting off with ethics and governance of AI for health in the pre-LLM era. There were some specific topics given around aging and AI. There was specific guidance given around regulatory considerations in 2023. And then just this past year, an adaptation of the previous AI frameworks for large language models, largely talking about what the potential unique risks of LLMs could be. Now, just from the perspective of someone who sits on AI governance for my health system, but many of you do as well, I think we have to situate these ethical frameworks in the context of many of the other frameworks that we are being, I would argue, inundated with, and because it does feel like we're drinking from a fire hose a bit. So when you think about non-ethics related standards, regulatory and development standards have been promulgating quite a bit, and we as health system governance leaders are largely responsible for trying to understand these. While they're enforcement mechanism and while they're intended to be largely guidelines for developers, we as end users want to be aware of whether these frameworks and whether these principles are going to apply for devices that we might decide to take up in our own health system, because we can interrogate some of those developers as to whether they're holding themselves to these principles. So things like predefined change control plans for algorithms that may be self-updating, or whether algorithm developers are adhering to good machine learning practices. Those are somewhat useful, and we're responsible for reading them. There's many action plans that have come about for things like software as a medical device from the FDA and from the European Union as well, most notably with the European AI Act. And then even in the non-regulatory space, there have been many other frameworks released by the White House in the United States through executive orders, but also risk management frameworks through organizations like the National Institutes for Standards and Technology in the US, various third-party organizations like the Coalition for Health AI that seek to try to empower local organizations and give standards for local organizations on how to monitor their AI technologies. And then, I realize I'm coming from a US-centric standpoint, but there have been many governance frameworks released in countries like Singapore that have attempted to come up with some country-specific guidance as well. So I think the point of this slide is just to say we have a lot to read, and it's not just ethics. But when you think about ethical frameworks, there tends to be some framework convergence around a few core principles, and I've listed them here: human-centered design, transparency, accountability, fairness, privacy protection, and safety and robustness. So you'll see these mentioned in some respect throughout all of these frameworks, and I'll go through a couple of these illustrating some healthcare-specific use cases. Now, I think the thing that I'm going to ground the talk on is through the 6 consensus principles from the World Health Organization that were released in the original 2021 report. And these consensus principles, we heard a little bit about, but they are autonomy, the fact that humans should remain in control and understand the role that AI is playing in their care; human well-being, safety, and the public interest, so maintaining regulatory requirements for safety, accuracy, efficacy, and quality control; transparency, explainability, and intelligibility, which was the first time I heard that word; sufficient information to be intelligible to clinicians, patients, and end users these AI tools should have; responsibility and accountability, who's in charge for monitoring these AI tools as they're implemented in the health system context, and what are the points of human supervision that we ought to be standardizing in their deployment. Inclusiveness and equity, so trying to ensure not only the greatest possible access, but trying to make sure that these tools are not baking in biases in their outputs. And finally, AI tools being responsive and sustainable. So do they promote sustainability of health systems, the environment, which is a big concern given the application, the huge environmental footprint of large language models, and then sustainability of workplaces. Okay, so I'm going to now pivot to talking a little bit about how some of these ethical frameworks may break when deployed. So let's just take one case example, so this principle of autonomy. So, if you read the WHO framework, it mentions that humans should remain in full control of health systems and medical decisions, and AI systems should be designed to assist medical providers or patients in making informed decisions. There's also a statement about how AI technology should not be used for experimentation in humans without valid informed consent. Totally reasonable in broad strokes. But I think there's a few points that are of a little bit of fuzziness here. So one, the boundary between assistive and autonomous AI is increasingly blurred, I would argue, and I'll give a couple of examples. Shared decision-making with patients is really difficult normally in medical care, let alone when it comes to trying to explain something complex like AI, particularly given varying levels of literacy with regard to AI compared to how a patient may understand their own health condition. And then unclear scenarios where informed consent would be necessary. And so I might argue that this principle of informed consent for every situation AI is deployed is somewhat unreasonable. So let's talk about this dichotomy between autonomous and assistive AI. So this is actually, been formally articulated by organizations like in the United States, the Department of Labor, and largely centers on whether the response execution of what the AI is generating depends on a clinician versus the AI tool. So autonomous tools, the response execution it relies on the AI, something like an automated referral to a cardiologist for a malignant arrhythmia of the heart, versus something that gets interpreted by a clinician. So we act a lot like AI is autonomous. We pretend like the AI is doing this, the AI is doing that. One example might be the autonomous interpretation of the arrhythmia that has been marketed on your smartphones. Some people have. I see some people on the airplane having that. And so what matters with autonomous AI is largely accuracy. Is it getting things right? I would argue, though, that we're still in a state where most clinicians, certainly, and patients are not really comfortable with an AI taking a human out of the loop or a clinician out of the loop. And so most AI in health is assistive, still interpreted through the lens of a clinician. And so what matters for assistive AI isn't necessarily only accuracy, it's does the physician or end user trust it? And I think that's where there ends up being the need to focus, like Jess was mentioning, on how humans and clinicians are interacting with a tool, because a great AI algorithm that has a poor interface is just going to get thrown in the bucket the same way that all the bells and whistles that we have access to don't get utilized in normal clinical care. Now, there's been this advent of devices that are really straining this divide, I would argue. So, a prototypical example I think about is automated screening for diabetic retinopathy. So this is one of the first devices that was granted payment in the United States. It was given a CPT code and has been increasingly marketed and deployed. Its intention is largely to take a primary care clinician out of the loop of screening for diabetic retinopathy. In fact, if this device screens you, you can't bill for it if you're also going to bill for a primary care clinician also screening for diabetic retinopathy. So the intention is to have more of an automated screening for this potential complication of diabetes. So you might still argue, well, there's a clinician who acts on the response of that tool. The intention is to sort of provide a self-referral to a retinopathy specialist or an ophthalmologist. But there's still at least an ophthalmologist that's in the loop making sure that this diabetes tool didn't go awry. But you can see that that's still a little bit of a gray zone, and how we regulate this tool feels a little bit different than either a purely assistive or purely autonomous AI, I would argue. But these tools are effective. You can see that from their randomized trial, they have increased screening for retinopathy and the times that they're used at sites that actually deployed the tool compared to sites that didn't. What about a different use case? So this is a more purely assistive use case, using mortality prediction to try to direct early conversations around end-of-life care to patients with cancer. So this is a trial that we actually ran where we developed a tool based on structured electronic health record data and came up with a pretty good risk stratifier between high versus low risk of mortality, deploying it in the setting of a behavioral nudge to clinicians to try to nudge clinicians to have earlier end-of-life conversations. That responded in an over 5-fold increase in rates of conversations with some savings near the end of life. So this was a tool that was deployed in an assistive fashion. Clinicians were clearly instructed that they could interpret the tool how they wished. But we actually asked clinicians afterward, did you disclose whether a tool was prompting you to have the conversation or not? And many of you might have priors on whether that should happen. But we actually got a range of answers. Some clinicians argued that we had an obligation to disclose it to patients, and disclosing that it could potentially cause harm if this was deployed in an inaccurate way. And you can see some quotes here about how clinicians said that disclosure is important because this might actually change decisions. But actually, most of the clinicians argued that this was the same use case as another laboratory or another input that they might get from a diagnostic test. And they said, I interpret it in the context of my other inputs, and I wouldn't necessarily disclose it 100% of the time. So a little bit of a varying thought on whether disclosure ought to be upheld most of the time, even though disclosure is very clearly articulated in ethical frameworks like the WHO's. What about a different framework, explainability? So, if you read the frameworks, there's clear statements that AI technology should be explainable to the extent possible. Those who might request or require an explanation should be well informed. Well, there's some practical challenges around this as well, most notably that many of the modern deep learning tools are clear black boxes with technical complexity that may not enable a rich explanation and may have, and there's time constraints in a clinical setting around how much time we actually have to go through an explanation from an AI, no matter whether it's right or wrong. The emphasis on explainability is important because it largely gets down to the individual decision that's being made for a patient. If you think about disclosure that an algorithm is used, that's really the tip of the iceberg. There's certain needs for risks and benefits around intelligibility of algorithms and the obligation to identify individual and group risks around that. Somewhere in there is false transparency or making salient what actually goes into the algorithm. But then at the bottom of the iceberg, which is where we're really working towards, is explainability. What contributes to a decision that's made for a particular AI for that specific patient? And I would argue that this is where there's largely a gap in methods, not in the desire to have an explanation. So this is a radiology report from a patient with a very concerning lung nodule, indicated by the white arrow there, that was fed into GPT-4V, and you're asked to design an explanation around it. And what came out was the following. The chest CT images demonstrate an opacity in the left upper lobe measuring 1.3 centimeters in diameter, and then it made this comment about how it's concerning for a primary lung malignancy. Well, many of you know who read X-rays, so this is actually on the right side of the lung, not the left side of the lung, so there's an inaccurate explanation being given there. And there's also just a clear inability to make a size determination from this nodule based on a single image. You have to scroll three-dimensionally to actually determine the full size of a nodule like this. But yet the AI is projecting an explanation and projecting confidence in that explanation, and that's tricky. So when we place these demands on explainability for AI, these have to be interpreted in the context of where the technology is. Just as a bit of an aside, we've been doing research into more symbolic representations of AI that merge some of the accuracy and expressivity of deep learning with underlying rules that adhere to either heuristics or standards, like the need to present information in terms of a threshold for AI tools. And we are beginning to explore this in the health clinical decision support context, but this may address some of the concerns around explainability. What about this framework of accountability? And this will be the last framework I go through, I think, before I talk about need for local governance. So, there's a clear statement in the WHO framework that appropriate mechanisms should be adopted to ensure questioning and redress for individuals and groups adversely affected by algorithmically informed decisions. Now, while that's important and a clear goal to ensure that there's someone who can even direct a question to, there's some practical challenges here. For example, there's multiple stakeholders that are involved in the algorithm deployment process, somewhat unclear liability frameworks, as we'll hear about in a later talk, underdeveloped incident reporting mechanisms, and several issues with version control of the actual underlying algorithm. So who's accountable for what in that system is oftentimes really tricky. This oftentimes comes up in the deployment of predictive AI because we know that given a static model, that model is likely to degrade in performance over time. And so there's somewhat priorities to refresh or retrain models over time to prevent expected performance drift. But retraining a model, especially in the local context, is not without consequence. Do you have the right data to retrain a model? Do you know what a set threshold is for actually retraining a model? We experienced this during the COVID pandemic when deploying this example model in our health system that was used for palliative care and advanced care planning prediction that saw a clear decline in performance and sensitivity during the months of the pandemic because people were utilizing the health system in completely different ways compared to when the model was originally trained. But who decides whether the model ought to be retrained or just completely abandoned due to this performance gap? And if you do agree that it should be retrained, when should you, and who decides that? So these are some of the frameworks for accountability that aren't necessarily well specified in these frameworks and where there's an opportunity for local structures to intervene. I want to argue that the advent of large language models are further going to strain accountability mechanisms in healthcare, just given the huge amount of data touch points that they have access to. So, ambient scribes is something that our health system uses, increasing amounts of health systems are using. You can see some trends here. Here's a quote from my own health system that ambient scribe pushed my retirement by at least 2 years. So, people really like this technology. They feel like it saves them time in the clinical office. But there's this, phenomenon of model collapse that's been well described for large language models that are trained on synthetic data. And so when you think about what the training source for these ambient scribes is going to be in forthcoming years, they may be increasingly trained by LLM-generated notes. And so it's been well described that LLMs tend to revert towards the mean when it comes to generation of output. And so if you're increasingly training on homogeneous populations of LLM-generated notes and not those edge cases, there's been a well-described phenomenon of performance degradation of large language models. And I would argue that electronic health records are a perfect setup for this, given that they're highly templated, they have low information density. You have to scroll down to the bottom of the note to get to the part you actually care about. There's routine use of biased and pejorative language, like disheveled, non-compliant, a patient is complaining of something. And there's a high use of copy-paste with a low prevalence of some actual rare cases. So we need to be very careful of this when we're increasingly deploying this, and who's accountable for monitoring this degradation is still very open. So what metrics do we track? How we counter against automation bias, and then the volume of touch points, I think are key challenges for accountabilities in large language models. I'm going to skip over this use case just so we can talk a little bit about local governance, because I would argue that these strains that are placed on centralized ethical frameworks are really ripe for being managed at the local level if we're empowering health systems and users correctly. So, when you think about how to better enforce ethical principles in AI development, there's this so-called moving from soft law to hard law, actually coming up with legislation to hold people accountable. And this could be applicable for greater enforcement of select regulatory standards or implementing compliance principles about collections, storage, and use of health data, and enforcing just the presence of a local level governance committee. But generalizing from the quality improvement movement in the United States, which is not perfect, but largely succeeded in standardizing quality reporting and quality tracking by not by hard enforcing what metrics ought to be tracked, but rather by giving frameworks for selecting different frequency of reporting mechanisms, timing of reporting mechanisms, and the actual quality metrics themselves, and trusting that health systems would pick the metrics that they cared most about and that were most applicable to their care settings, while still having some overlying centralization. That might be a framework for ethical assurance in AI that we ought to be thinking about. And these are just some examples of organizations that have tried to adhere to this framework of putting forward some select quality metrics while still empowering local level organizations to explain the how to do quality improvement. So some potential avenues for local governance standards include having local level ethics committees with some level of AI expertise, standardized assessment tools for assessing various aspects of the principles that we have been talking about, having regular stakeholder engagement, having clear escalation pathways when there's potential errors or issues with an AI tool, having auditability mandates, I'll talk about in a second, and then empowering local policy development. So in my own work, I've been really interested in this concept of medical algorithm audits, where you may give some templates for audits for deployed algorithms to local organizations and essentially ask them to fill out the details themselves. So that may range from scoping the deployment of the algorithm and understanding its intended use to actually mapping the system, the task that it's supposed to be responsible for, having a checklist, an audit checklist that goes through not only the use statement, but failure modes monitoring and data flow diagrams, actually clarifying the testing of how you're going to evaluate the performance of the algorithm, and then reflections and post-audit mechanisms as well. So this is a framework that I might argue that is useful to at least help guide local level organizations on how to be auditing their tools. Other potential ideas drawn from the literature on how to facilitate local governance, so tailoring subgroup analyses for bias assessment to local level context. For example, if you're a rural health system in Oklahoma in the US compared to an inner city hospital in Atlanta, you may be evaluating bias somewhat differently towards different subgroups. Having templated and standardized AI clinical protocols, particularly for prospective evaluations of AI. Having templates to promote transparency and disclosure of AI to patients, the same way that we have checklists for disclosing medical errors or bad news to patients. What if we had templates for how we were going to disclose the potential use of AI? Dedicated error reporting systems, regular performance reviews, documentations of use and decision support, and then dedicated training for AI literacy that's intended for individuals and system-specific training as well. There's some element that you might argue that this is sort of AI exceptionalism, and we should be incorporating this into our routine frameworks because these exist outside the context of AI as well. And I would totally agree with that. There's no need to reinvent a wheel that doesn't need reinventing. I want to run through just very quickly a case example of a sepsis prediction model that I think embodies some of these principles well. It was a local level deployment of an EPIC, an electronic health record sepsis module for predicting sepsis and empowering action upon it. That had some pretty impressive decreases in adverse events, as you can see in the red here. But I think what's more important is to talk about how this was developed. This was a published deployment that came out earlier this year that involved not only an initial assessment, stakeholder engagement, protocol development, training of end users, standardized monitoring, and regular review, but that articulated this akin to the audit framework that you saw previously, and I think is an really interesting example of where local level organizations have picked up the wheel that centralized governance frameworks may have left behind. Now, despite these outcomes, there's a clear need to sort of have some broader accountability and broader level testing, since we know that some of these tools, sepsis modules in particular, may generalize poorly. So this isn't an argument to just leave everything to local level organizations, but it's largely to have a more yin and yang rather than relying purely on centralized frameworks. The last thing I'll say is that there are repositories for self-governance frameworks that local level organizations can look up if they're looking to look up specific standards around a particular ethical principle or even beyond ethical principles. So this is a framework that the OECD has come out with from its Policy Observatory Lab that I think is particularly useful for standardizing some elements of self-governance. So that's the last data slide, so I'll just close with the key points again, that soft law ethical guidance is plagued by low uptake and poor translatability for end users, and that broad tenets of guidance have these fuzzy edge cases that may decrease trust, and that we ought to be empowering local level organizations with self-governance standards to pick up where some of these principles are leaving off. So thanks very much, and looking forward to the discussion.
Welcome back, everybody. And to all of you who cannot hear me because you're not here, shame on you. Where are you? We give the late people a couple of minutes because I can see down there that someone is being late, much to my disappointment. Okay, I think we're all here. Thank you for being on time. I know that this has already been quite a long day, despite the fact that we started quite late. But we have much to do and quite a number of speakers to listen to. We first have a keynote and a respondent, and then we will move straight away to the panel. I'd like to make a slightly different change in the program if we can. I can see that there are some closing remarks, which I can definitely skip, instead provide more space for some questions. I know that there were more people with more questions that we could address. So depending on how we march through our timeline, keynote first, respondent, then straight into the panel, and then hopefully a little bit of time for more Q&A. So I welcome here Emily. Amelia, where are you? And please join me to welcome her. Thank you. The floor is yours.
Thanks so much. It's really a pleasure to be with you here in this beautiful place. If there's one way that you can spot an anthropologist in the room, it's because we're very attached to our notes when we present, and it's because we're always yammering on about context. So for better or worse, I'm going to fulfill both those stereotypes today. Apologies in particular to Glenn. So AI has, of course, been proposed as a tool that could help us to address existing global health challenges. Oftentimes, this is linked to our ability to achieve sustainable development goals relating to health, or there are promises made that somehow this could enable cost-saving solutions to expand healthcare access, in particular to lower resource groups. And this vein of work fits within a broader expectation that AI could help us to solve complex problems in medicine, including as a means of addressing very persistent problems in health equity. But I think one thing we could probably all agree on is that it's very clear that AI is not going to be some kind of magic bullet in this scenario. In the past decade alone, we've seen a very significant push to address really serious issues around the technical context of AI, and by that I mean algorithmic bias or clinical performance, safety, and more. And of course, this work is absolutely essential. We can't do AI without it. But a narrow focus on algorithmic improvement is going to miss the broader context that's required for AI to actually work. So what I'm going to do today is I'm going to try and argue to you for why an attention to context needs to be made central to debates over AI and health equity. So I'm trained as a medical anthropologist, and I take inspiration in my work from feminist STS and applied bioethics for thinking about how we can advance more relational approaches to AI. So in this case, when I'm talking about context, I'm referring to a particular kind of commitment to understanding AI and global health as part of this relational, historically situated ecosystem that's structured by multiple layers, multiple levels of inequality. So in order to do this, what I'm going to try and do today is to knit together two areas of research that I've been working on. The first has to do with the context of where and how AI is deployed in global health. So this has to do with trying to identify the investments that are needed in order to translate AI into better outcomes on the level of healthcare systems so that we can promote equity. And then after that, I'm going to try and turn to the specific context of AI. And I think that this is necessary because technologies, AI or other technologies, are never neutral. So addressing the context of AI also requires grappling with the structures of extractivism, of coloniality, and of a general lack of participation that threaten to undermine our work towards global health equity. So in this talk, I'm going to refer to global majority and global minority countries. And I was inspired by this by a white paper by Sumaya Adan. It's called Voice and Access in AI, where they make this argument that this is a more productive way in thinking about questions of power and AI. So global minority captures this sort of growing concentration of access and ability to shape AI development and governance in a very limited number of countries that have advanced AI capabilities. Whereas global majority, by contrast, is a term that can capture sort of the exclusion of most of the globe in AI development, deployment, and being able to shape the direction of these technologies. So matters of technical context are, of course, very established concerns within AI. A lot of time, this is what we're talking about. Performance, safety, bias, how we integrate ethical principles into AI development. But I'm really interested, of course, as an anthropologist, in a different kind of context. So I'm interested in a commitment in which we understand AI and global health as structured by existing forms of economic systems, political decisions, and social hierarchies that both create and perpetuate health inequalities. And I think that these kinds of questions around context are very often sidelined in debates that lean quite heavily towards techno-optimism. So, of course, my interest in context comes from my training. Context is maybe one of the longest-standing commitments of the discipline of anthropology over the 20th century, right? We can think back to some very early field-shaping references from people like Malinowski, who argued that we can't understand social institutions if we extract them from their social relations, right? And since then, of course, context has developed so that we're not just thinking about as an object of interpretation, but rather it's an argument for a mode of interpretation in terms of how we approach social problems. So without going too far afield into the relics of anthropology, I'm going to try and convince you that these kinds of anthropological commitments have a lot to offer questions of equity and global health in relation to AI. So for the past year, I've been thinking about some of these questions with a group of scholars who I'd like to give credit to. They're on the slide here. They're a really great group of people, sociologists, physicians, computer scientists from all over the world. And we've been thinking about how we could apply physician and anthropologist Paul Farmer's work in promoting the social and economic rights of the poor as a central agenda in global health, and how we could adapt this to questions of AI and global health. So specifically, we've been thinking with the 5S framework, which was the 5S framework of partners in health, which refers to staff, stuff, space, systems, and support, and then asking how this could help us to guide health system development in the age of AI. So don't be alarmed. These are actually very, very straightforward things, but they're things that are often forgotten in conversations about how we can use and make good on AI. So the first S in Farmer's framework is staff. And this has to do with this sort of fundamental recognition that healthcare systems are fundamentally human enterprises. So without trained staff who are accessible, who are able, who are available to provide care for families, for patients, we simply won't have functioning healthcare systems. And across the globe, staffing shortages remain a consistent problem. We know very well that the poorest regions suffer the greatest burden of staffing shortages. So these kinds of questions should prompt sort of a very initial reckoning around how can we responsibly promote the inclusion of AI in healthcare systems if we have some that don't have sufficient trained medical staff to provide even basic care. More broadly, and I think this has already come up in some ways in the earlier conversations today, these questions between healthcare staff and AI require very careful consideration. AI is often suggested as a tool that could empower clinicians, or that maybe it could even resolve some of these staffing shortages by automating certain aspects of clinical care. But if we look to the history of medicine and technologies, this would suggest that we need a bit more caution in these kinds of predictions. Looking to the past at the integration of other kinds of, at the time, novel medical technologies, there's the risk that the introduction of AI technologies could consolidate power in the hands of administrators or tech vendors. There's the risk that AI could contribute to the erosion of professional autonomy, that it could displace clinical judgment, or that it could exacerbate existing disparities, both within healthcare systems and also between global majority, global minority countries. So these kinds of lessons from the study of medical technologies in the past suggest that we need to focus on strengthening and empowering healthcare workforce, and this needs to precede and not follow our introduction of sophisticated technological tools. The second S is stuff. So this has to do with the essential materials that are required for effective care. Like with staff, again, we feel that there needs to be a focus on how overlooking these kinds of realities, questions of availability of medicines, supplies, and equipment, the essential goods that any healthcare system needs, can't necessarily be taken for granted in global health. So last year, in 2023, the Bill and Melinda Gates Foundation announced this $5 million investment as a push to try and fund AI large language models in low and middle income countries. But I think it's already clear that we can't simply leapfrog using these kinds of sophisticated technologies, fundamental questions of material scarcity. So AI tools might be able to propose optimal treatment plans, but this is going to mean absolutely nothing if we don't have reliable access to the material goods to actually follow through on the treatment recommendations. So we could think, for example, we could really take any example for this, but think about the case of sepsis. If you had an AI system that could perfectly predict sepsis every single time, if you don't have access to antibiotics, to fluid resuscitation equipment, to monitoring devices, these kinds of predictive systems cannot, will not, translate into better patient outcomes. So in this sense, we need to be thinking about the question of stuff as it's linked to broader structural factors and questions of political economy that shape the kinds of differing access to the materials of healthcare. We could look here to relevant lessons to the history of global intellectual property regimes and pharmaceutical pricing structures that at different points in times have rendered life-saving medications unaffordable in precisely the places where they were most needed. So we need to make sure that this is not happening with AI technologies. These same kinds of structural barriers that have limited access to essential medications in some cases still affect many healthcare systems today. This also means thinking about building strong supply chains. It means building inventory systems. It means local manufacturing capacity. All of these kinds of very straightforward, basic improvements that we might take for granted coming from a place in the United States or in Germany or certain parts of Europe are going to reap potential benefits for the delivery of healthcare. And these will continue to need to be prioritized before we are considering other advanced technological commitments like AI infrastructure. The third S of the 5S framework has to do with spaces. This has to do with the provision of safe and appropriate spaces, physical spaces to provide medical care. So in considering what's required for AI, this is in many ways a very similar observation to the prior two S's, that many healthcare systems still struggle to provide basic, dignified physical spaces for care delivery. In many parts of the globe, healthcare systems are operating without access to reliable electricity or clean water or adequate infection control infrastructure. So it may seem obvious to state, but a hospital without access to reliable power or clean running water can't possibly implement AI systems in a meaningful way, no matter how potentially good they might be. And of course, going beyond simply these questions of the bare minimum, we also need to be thinking about creating spaces that are accessible, that are culturally appropriate, that are designed to preserve dignity and privacy. And this is also about questions of access. Can people get into the clinic? Do they have the money to do that? Is there public transportation available for that? Are there other kinds of social barriers that we need to be thinking about in terms of accessing the physical spaces of healthcare delivery? And of course, in the age of AI, we're not just thinking about physical spaces, we're also thinking about digital spaces. And in this case, I really think that digital spaces need to be understood as a potential extension of, but not a replacement for, the physical spaces of providing care. And it's easy to see how in places where basic infrastructure is precarious, or you don't have access to reliable electricity or other concerns, that there will be additional challenges to digital security and privacy without these kinds of basic reliable internet connectivity, data storage capabilities, or cyber security infrastructure. So the fourth S has to do with systems. And this is really a focus on governance structures, to pick up some of the conversations that have already begun today. And we know that governance structures tend to reproduce existing hierarchies. And in some cases, this may mean that those who are making decisions about how AI is implemented are actually furthest from the provision of patient care, right? This can include, some cases where a push for so-called AI readiness is coming from external actors who may have very limited understanding of local priorities or how local context is going to need to be considered in those plans. So with this in mind, it's really essential that we're thinking about good governance as preceding the implementation of AI. Many healthcare systems lack robust governance structures for existing technologies, let alone AI. So we need to have these kinds of frameworks in place for clear oversight, for accountability, for ethical decision-making that are essential to all aspects of healthcare delivery, whether we're thinking about basic medical procedures or advanced technologies. And in doing this, I think that we need to be prioritizing local leadership. We need to be prioritizing local expertise and fostering that kind of expertise, because local healthcare workers and communities are going to understand the systemic constraints and opportunities of their context in a way that others will not. And this also includes an evaluation of opportunity cost in terms of how a given investment, say, in an AI system might compare to other investments in basic infrastructure, essential medicines, or workforce development in places under severe resource constraints. And this is also an argument that IT infrastructure needs to be understood as a systemic concern. So all of these questions of data governance, of privacy, of security, these are also questions of power relationships, of who's controlling health information, who's deciding how it's used, who's going to benefit from its analysis. So in this sense, we need to think about the building of robust IT systems in order to improve patient care, even in the absence of AI tools. And the final S of the 5 S's has to do with support. So this is a shift to the kind of broader social and economic context, the sort of ecosystem in which a healthcare system is operating. And this includes everything from local safety networks or mutual aid platforms to food security or transportation. And I think this is sort of one of the central components when you look at Paul Farmer's work, was to insist on these kinds of factors because very often these have the greatest impact on a patient's ability to benefit from available care. So if you had a system, for example, that could optimize medication adherence, even if the system were technically perfect, if patients can't get prescribed medications, if they can't get to the pharmacy, if they are working too many jobs such that they cannot adhere to that medication regimen, then this system is not going to be helpful. We need to be addressing these sorts of broader social structures and supports that are necessary for the delivery of care. And I think here it's also important to think about legacies in some places of medical mistrust, where we need to be also engaged in meaningful community engagement and trust and openness in order to repair some of those histories. Otherwise, the introduction of AI in cases of significant medical mistrust can risk deepening these sorts of existing inequalities. We saw this quite clearly in some places during the COVID-19 pandemic. So the promise of AI in global health has generated significant enthusiasm, but the reality is that most healthcare systems in the global majority are nowhere near ready for meaningful AI implementation. And this is again what Jess brought up earlier in terms of the implementation gap, where we have these kinds of continued investments in AI without corresponding improvements in healthcare outcomes. And here the research is quite clear that, although we have thousands of models that are developed in medical AI, we have very little empirical research on observations of these deployments in medical context. And we have even less empirical research on how this is done in global majority countries. So this is also what our correspondent Enrico has termed the last mile of AI development, sort of this need to shift focus away from the technical performance of algorithms alone to these questions of implementation and the actual ability of AI technologies to address real-world problems in practice. So the argument of this sort of the 5S framework applied to AI is that in healthcare systems that are struggling to provide basic care, or that lack essential supplies, or don't have enough staff, or don't have the infrastructure they need, that prioritizing AI is not just premature, that actually it risks multiple kinds of negative outcomes, and it could even undermine healthcare delivery by misdirecting scarce resources. So thinking about context in global health shifts our gaze away from the potential of AI, the sort of shiny object effect of AI, to the very conditions that are required for AI to actually make good on that potential. So I think that a closer look at context, what I and the people I've been thinking this through with Farmer's 5S framework can be kind of a helpful orientation to thinking about the conditions necessary for thinking about equity in global health. And as you've seen so far, actually these conditions have very little to do with AI itself, right? These are conditions that would apply generally to flourishing healthcare systems that meet the needs of their patient populations. So staying with the focus on context, I'd now like to shift away from the context of where we are deploying AI systems in global health and think instead about the context in which AI has been developed and the implications of this for questions of global health equity. So in Farmer's scholarship and in a lot of critical medical anthropology, there has been this emphasis on structural violence, meaning the kinds of sort of social arrangements that put individuals, but also communities, in harm's way, and that create the kinds of disparities that we see in the provision of high-quality healthcare. So structural violence is a very intentionally broad analytic. It includes both symbolic, but also social and material processes to think about how it is that some groups have historically, cumulatively benefited, while others have been subject to the cumulative effects of marginalization, dispossession, discrimination, racism, coloniality, homophobia, on, and then how these factors are then reinforced through questions of political economy. So I think that when we don't attend to these social, economic, political determinants of health and well-being, the risk is that AI remains a tool of technological idealism, or that worse, in context of structural inequality, it becomes a tool of structural violence. So if we're invested in global health equity, then we need to look not just at the conditions required for AI to do what we want it to do, but we also need to address the kinds of context in which AI has been developed. And I'm going to try and do this in 3 ways, but I would also love to continue these conversations with you over the next couple of days about other areas of this that we need to be thinking about. But for me, 3 key areas of this include the environmental demands of AI, the sort of extractivist, colonialist structures in which it has emerged, and then this broader question of participation and the ability to shape AI and the kinds of AI we want in global health going forward. So AI is one of the world's most resource-intensive digital technologies, and it's increasingly clear that the environmental impact of AI technologies needs to be an urgent matter also of global health. And this has to do with the health effects of climate change. So on the one hand, we have major players in the tech world who have sort of positioned themselves as possibly agents of sustainability, right? We have leaders from Microsoft or Google or other places who have touted their net zero carbon goals or their efforts to reduce water, for example, by 2030 or 2040. But these kinds of sustainability goals or greenwashing aside, you know, the rise in large language models and generative AI in just the past couple of years alone suggests very alarming trends in relation to water consumption and energy use. So the data centers where AI models are trained and deployed use immense quantities of water, both for on-site cooling and for off-site electricity generation. And if we look at 2022, Microsoft reported consuming 6.4 million cubic meters of water. This was 34% more than the prior year. So most of this, presumably, was used for their cloud data centers. We don't know because it's proprietary information. But given the rise in large language models and generative AI, the assumption is that that's where this nearly a third increase comes from. In other cases, researchers have estimated that globally, the demand for AI could result in between 4.2 to 6.6 billion cubic meters of water being withdrawn in the year 2027. This would be more than the total water use of a country like Denmark. So when we put these kinds of numbers in a global perspective, the sort of disparities in resource use are ever more striking. The average annual cooling system of a small data center in the US is 2,000 times more than the water usage of an individual living in, say, Nigeria. The same kind of patterns hold true also for energy. So the researchers behind the carbon tracker tool have estimated that the energy costs of deep learning have risen 300,000-fold between 2012 and 2018. And in one study, the training of a single big language model was found to generate emissions that were equivalent to taking 125 round trips between New York City and Beijing. So even when we take middle range estimations about the energy footprint of AI, these propose that in the year 2027, the energy demand of only new AI servers that were sold in that year could be as much as the entire annual consumption of countries like Argentina, Netherlands, or Sweden. We've also seen, for example, cases in the US where Microsoft recently bought a nuclear reactor on 3 Mile Island. Or, for example, a power company in Omaha, Nebraska reported that they would have to abandon their plans to stop burning coal because they needed to meet the demands of nearby Google and Meta data centers. So this is to say that the infrastructure required to support AI has an explicit carbon cost, and it means that when we're thinking about how we can use AI to promote health, there are real trade-offs between climate goals and AI development that we need to be considering. So to bring the focus back on global health, it can't be lost on us that these kinds of patterns of accelerating natural resource consumption driven by AI are really relevant context for the application's ability to address health concerns. So we know that the development and training of AI systems contributes to climate change, and we also know that climate change is contributing to hundreds of thousands of additional deaths every year from things like malnutrition, malaria, heat stress, and more. We also know that those affected will be vulnerable populations who are living in places with healthcare systems that are least prepared to address these additional healthcare burdens. So this is structural violence. We can't ignore that these kinds of AI solutions in global health are, to some extent, exacerbating the very problems that they pretend to address. So this brings me to a related second area of critical context in AI, and that is that the structures of AI development are extractivist. So extractivism is a term that has emerged out of locally situated critiques of historical modes of accumulation. A lot of this comes out of places with oil or mining or other kinds of natural resource use, but has since broadened to also include these kinds of socio-political elements, such that we can also think about extractivism in relation to labor or to data. So in the book Data Grab by Coldry and Mejias, they propose that big tech is a form of data colonialism. So this is a study that looks at the ways that how in the past coloniality was focused on the capture of territory or wealth or crops or knowledge, that today it has to do with this wide-scale extraction and appropriation of our data as the raw materials of corporate profit. So they argue that this kind of global, large-scale capture has generated not just immense wealth, but has created this kind of new social and economic world order that continues legacies of dispossession, injustice, and unchecked resource use that we saw under colonialism. So bringing our focus again back to the question of AI and global health, the history of global health is also a colonial history. So I use global health here, but of course, prior iterations of this included international medicine or tropical medicine, colonial medicine, and these kinds of histories continue to shape the formations of public health, global health, humanitarian aid as we know them today. So if we look to the work of somebody like Richard Keller, historian, has argued that modern medicine has operated in a colonial syntax, meaning that for many people in global majority countries, their first encounters with biomedicine was with colonial medicine, where health officials and programs were an extension of very oppressive political and economic powers. This included also so-called civilizing missions, which overlapped with projects of development, and racist conceptualizations of biological difference, and even in some cases, medical experimentation. And I think that we continue to see legacies of this within global health, within medicine today. For example, longstanding ideas about Black people being stronger or better able to endure pain, which continue to affect known disparities in pain management, or ideas about Chinese people as carriers of disease, which we again saw reemerge during the COVID-19 pandemic with newfound fervor. And so in the past couple of decades, we've seen these calls to decolonize the field of global health. And some have argued that this can't just be about the content of global health, but this has to be about the terms under which global health is enacted. And I think that this point is really relevant for thinking about AI. coming from the work of Coldren and Mejias, they've argued that our encounters with AI have already been structured, or even foreclosed to some extent, within the logic of data colonialism. So while much of AI tech development is centered in global minority countries, AI systems are increasingly being incorporated into international development projects and global health programs in the global majority without this kind of attention to critical differences in infrastructure, history, or culture. And this is what Abiba Burhain calls algorithmic colonialism. That is a colonialism that's driven by corporate agendas in which AI solutions are proposed for medical or social problems, creating new forms of dependency on Western software and infrastructure. So where does this leave us in considering the context of AI in relation to global health? As somebody like Kalourdi has argued in a really excellent short piece, don't ask if AI is good or fair, ask how it shifts power. So the increasing concentration of power to direct global health in global minority countries should prompt us to ask who's setting the agenda in global health for AI? Which applications are considered worthy of investment or intervention, and based on which priorities? So given the kinds of established concerns around the training of AI models on global minority databases, and also the sort of sustained investments that we would need in order to create robust databases in global majority countries, there are real risks that we need to be thinking about here. For example, that public health institutions could potentially become dependent on global minority companies for health tech intervention or innovation, or where public hospitals might be in a position where they have to give up protected patient data in exchange for infrastructural or algorithmic innovation, or in cases where AI is proposed for long-standing social or organizational problems, like that of staffing. We need to be attentive to the ways in which this can also introduce further stratifications of care, whereby some people continue to have access to high-level in-person care, and others are offered AI modalities which may not have sufficient evidence to back up their effectiveness. In this case, I'm thinking most obviously of the field of digital mental health applications. So the third area that I want to touch on is that of participation, or rather the imperative of including voices and a range of positions and perspectives of those who will be affected by AI applications. So on the one hand, the sort of geopolitical and arguably also epistemic diversity in the communities that are creating AI research communities, the lack of this is very well established. And this is a problem because we know quite well that when we have diverse teams of researchers, practitioners, even lay people, that this can help us to address some of these problems with algorithmic context, with fairness, with accountability, with transparency issues, for example. But on the other hand, we have sort of a generalized lack of participation among those who might be engaging with or affected by AI tools in global health. And I should give a little caveat here that in the past few years, there, of course, has been this sort of turn towards participation in AI, where participation is presented as though it will somehow solve all of our ills, or that it is in and of itself a more ethical way of doing AI. Of course, it won't solve all our problems, and it's not necessarily more ethical, but there are very good reasons for why we should be thinking about how and why we can cultivate participation in AI. So the kind of case that I'd like to make for participation has to do with participation as community building, which is essential for fostering equitable health practices. So in Farmer's framework, this took many forms, for example, in the Accompagnateur program for directly observed therapy, for example, but also in the building of top-of-the-line medical facilities in Haiti and Rwanda, and training local staff to create strong local healthcare systems. And when we think about the context where AI is developed, there are very, very limited opportunities for participating in AI for those who live in global majority countries. So here I'm thinking about work coming out of, for example, Constanze Chalk's work on design justice and how we can use participatory approaches to move towards equity in order to attend specifically to these questions of power and socio-political context. So this gets at, again, what Jess was bringing up around questions of intersectionality. These are ways of mobilizing an analytic of intersectionality in order to tackle systemic questions of injustice, in voice, in access, and broader systems of oppression. So this is a way, I think, in which participation can offer us this sort of critical appraisal and commitment to the kinds of infrastructure and resources that sustain healthcare systems, like in the 5S framework, which could include localized control over data sets, ownership and creation of data, or simply questions around the priorities of AI development in global health being determined by affected communities themselves. Oh, sorry, I missed the whole slide there. So, where does this leave us? So my intention today was to sort of borrow this very old classical trope from anthropology, which has been an orienting premise to my training and to my work, in order to try and show why context is critical for thinking about how we can move from promise to practice in global health with AI. And by tending to the context of AI applications in global health, we see that without these kinds of significant foundational investments in healthcare systems, we risk wasting critical resources for health, possibly even causing more harm than good. At the same time, the context of AI itself merits interrogation in relation to the possibilities of using AI to work towards global health equity. So we need to also attend to these kinds of structuring logics of AI, the sort of social, political, environmental implications of its use, through which I've highlighted these three issues that I think are particularly critical in this regard. There's a longstanding debate in global health around whether and to what degree global health interventions should focus on proximal versus distal interventions. And I think the beauty of a lot of critical medical anthropologists like Farmer was to insist that this kind of proximal distal opposition was a false choice, that we must provide both first-rate medical care and services to those in need, and we need to invest in building teaching hospitals, invest in community health workers, invest in the foundations of good medical infrastructure. And I think that the same is true for AI. So yes, we need to improve the technical context of AI, but we also need to address the upstream determinants of disease among the global poor and disadvantaged groups, and we need to address the power dynamics that have created and maintained this kind of status quo. So, of course, there's no singular technological solution that will resolve these problems, but by building and investing in necessary healthcare systems, this will be one step towards ensuring equity in healthcare. It will also offer us the possibility of making good on the kinds of potential that we see in AI. But at the same time, it's imperative to interrogate the context of AI itself, of how AI applications contribute to upstream risk of environmental extraction, of socio-political instability, and urgent health problems associated with climate change. So I think that the field of global health has a very long history of technological reductionism. And there's a tendency to look for technological solutions to solve these kinds of medical or social problems, which has then been confounded by privatization or a market logic of healthcare. But time and again, we've seen that those kinds of interventions fail. On the one hand, because the transformative potential of the technologies is oversold, and the other hand, because the complexity of the problems is underestimated. So AI is no exception to this solutionism trap. Moving from promise to practice in AI will require both building up healthcare systems, and it will require the intentional dismantling of systemic forms of oppression and extraction that gave rise to AI. Thank you.